Juhi? Okay, good evening, everyone. So, welcome to this session of Remarkable Rapid Revision 2.0 Radiology. A little bit about myself. I'm Dr. Aakif Reshamwala, and just last year, I was where you guys are right now, right? And I was fortunate enough to clear my NEET PG and end up on this side. So, just a few pointers before we start. Guys, radiology is a very easy and a very scoring subject. Okay, if you get all the questions right, which you can, it'll give you a big head start, okay, and a massive leap in your ranks. So please pay attention. And this is a lecture, so to call it, but this has to be an interactive session, guys. Okay, you have to put in your brains, you have to keep answering the questions. I may not be able to hear it, but I'm reading everyone. Okay, I'm reading all the comments and everything. So you need to do this for yourself, okay, not for others, not to see who has the most right answers or who doesn't know anything. Your competition is with yourself. Okay, after this session, you should be in a position in which you can say that I know radiology much more than what I used to know before this session. Okay, so the competition is yourself, guys. Believe in that, and trust me, after this session, you will be confident and you'll be able to answer all the questions correctly. I'm confident about that. Okay, so let's go. Right, so first things first. Okay, guys, this is an image. Okay, let's pay the respects. The first image is of a trefoil. Yes, it is a trefoil, and this is nothing but radiation hazard, symbol of radiation hazard, guys. Okay, it is a trefoil. Yes. It is a trefoil and symbol of radiation hazard. And the second photo is of William Röntgen. Okay, this was the person who first discovered X-rays. Okay, right. Now let's move on, guys. So at this session, at this point of time, you're very, ready to go. So let's get all the boring stuff out of the way initially, so that towards the end, we can take up all the photos and all the images. Trust me, we're going to see a lot of photos, a lot of images, right? So let's just get done with this boring stuff first. You need to know this. It's important. Okay. Right. So the session would be around, say, 4 hours, maximum 4.5 hours, not more than that. Trust me, guys. In 15 pages, we'll finish general radiology. Then in another 10-15 pages, each of the systemic radiologies will be done systematically. And we'll end with a brief talk on nuclear medicine and radiotherapy. Okay, guys? Yes, everything only that's important, only the very important stuff will be touched upon. I've tried to touch each and every topic little bit. Okay, see, guys, no one can know 100%. Okay, you need to know a bit of everything. That is the key to cracking the exam, to crack any exam. You need to know a bit of everything, not everything. Okay, right. So first, let's start radioactivity, guys. The conventional unit is Curie. Okay, so the way I used to remember this is that there is a C here and Curie. Okay, so this is what I used to remember. Radioactivity conventional unit is Curie, and exposure, there is an E here, and Röntgen, R and E. Röntgen, this is for radiation exposure. Radiation absorption dose, it is very simple, guys. RAD. Okay, the mnemonic itself is there, RAD. And equivalent dose, guys, equivalent dose, the SI unit must be remembered, that is Sievert, because we explain everything, we take up everything in Sievert. Okay, millisieverts or Sievert, this is what we used to express the equivalent or effective dose, right, guys? Okay, so moving on. Okay, exposure doses, guys. Exposure doses, a very simple way to remember. In X-rays, you go from top to bottom. In CT scan, you go from bottom to top. Okay, so if you see here, if you take a limb X-ray, guys, limb X-ray, okay, any limb X-ray, what is the exposure? What is the exposure or the effective dose? That is 0.01 millisieverts, guys. I've written it for you, 0.01 millisieverts. Okay, coming up to chest. Okay, if you go to chest, guys, if you go to chest, what is the effective dose or exposure? It is 0.02 millisieverts. Okay, and the spine, guys, lastly, the spine, it is 1. Okay, so what is the most important, guys? Which value do you think is the most important one? Of course, it is the chest X-ray. You need to remember 0.02. Okay, chest X-ray. So we're going from bottom to top. Okay, we're going from bottom to top. In CT scan, guys, we come from top to bottom. So we start with CT head. Okay, CT head or CT brain, as we call it. Okay, 2 to 3.5 millisieverts. Then CT chest. Okay, CT chest has to be 5 to 8 millisieverts. CT abdo, guys, is 10 millisieverts. CT abdo is 10 millisieverts, and PET CT is the maximum. PET CT is maximum of 25 millisieverts. Okay, so what you have to remember here is abdo is maximum in CT, but PET CT is more than abdo. Abdo is 10, chest X is 0.02. Okay, that's all you have to remember from this table. Let's move on. This is a TLD badge or thermoluminescent dosing badge. Okay, this is checked every 3 months. Now, all the people who work with radiations, the radiologists, all the technicians and everything, they wear this badge. Okay, this badge is worn below the lead apron. Okay, below the lead apron, and it's checked every 3 months, guys, every 3 months. And the principle is thermoluminescence. It's in the name itself. TLD, the principle is the first word T, thermoluminescence. Okay, we check it every 3 months. Right. Safety limits, guys. Safety limits. Questions is usually asked, what is the range, what is the maximum exposure that you can have? So overall 20 millisieverts per year. Okay, according to, yes, the guidelines, 20 millisieverts per year, such that over a period of 5 years it is 100. Okay, so it comes down to 20 per year, but maximum in 1 year is 50 according to international guidelines, and according to Indian guidelines is 30 millisieverts per year exposure. Okay, okay, you need to remember this, 50 and 30. 50 is international. International is bigger number, 50. 30 Indian is small compared to international, so it is 30. Okay, in pregnancy, yes, occupational is 2, general public is 1. Fetus occupation is 1, general public is half. Okay, so what is the most important one here? Yes, this is the most important, and the general public overall exposure has to be less than 1 millisievert per year. This is the most important one. Okay, yes, coming to lead apron, guys, you've seen all of this lead apron. Okay, you've seen in your hospitals, in the cath labs, we use this regularly. In orthopedic OTs, okay, when you use the C-arm, we use the lead apron. Okay, the thickness is 0.25 to 0.5 millimeters, guys. Okay, what is the most common value? Yes, the most common value is 0.5 millimeters. Okay, the thickness of lead in there is 0.5 millimeters, guys. Okay, yes. Okay, coming to effects of radiation. Yes, I know, guys, there are very few images till now, but just bear with me for another 5 to 10 minutes. I promise you will get past this stuff and the interesting stuff will begin very soon. Trust me. Okay, so DDD, I've made a very simple way to remember it. I remember it this way. Deterministic means dose dependent, develops early. Okay, it means it has a threshold. Example, skin erythema. Now remember, the most common deterministic effect is skin erythema. Others are acute radiation and cataract. Okay, stochastic effect is exactly the opposite. So remember one thing, guys, remember one thing, deterministic, the D's, deterministic, dose dependent, develops early, has threshold. Example, yes, skin, acute radiation and cataract. Every other thing, dose independent, stochastic. No threshold, stochastic. Late development, stochastic. Cancer, stochastic. Remember one thing and you'll know the other one. Okay, yes. Okay, so effects on organs and tissues. Again, this is a very common one-liner that is asked. Most sensitive is rapidly dividing. Okay, this is the law of Bergoni. The most sensitive cell to radiation is the one which is dividing very rapidly. Okay, so gonads and in the blood, lymphocyte. Least sensitive is the one which does not divide. Neurons, we all know the number of neurons we are born with, they remain the same. In stroke, when the neurons are dead, they do not regenerate, they do not recover. Okay, so neurons are not dividing, they are not sensitive. Okay, platelets are the least sensitive blood cells. Okay, cell cycle stage, again, cell cycle stage, the concept is the same, guys. The concept is the same. G2M is the stage where maximum division or replication takes place. Therefore, G2M is the most sensitive one. S itself stands for stationary phase. There is no division, there is no replication. So stationary phase is least sensitive to radiations. Right. Okay, guys, so acute radiation syndrome. Again, we saw this figure in X-ray and CT scan exposure. There is acute radiation syndrome, can be very easily remembered simply by this. See, okay, so the first one is here. We'll go in this direction. We come from outside down, then we'll go towards the top. Okay, so the first one here is hematological. Okay, so the blood system is affected first. The hematological system is affected first. Decrease in WBCs causes infection. Decrease in platelets will cause bleeding manifestations. Okay, yes, the next system is, yes, it is your GIT, guys. The GIT system is involved next, and the GIT system will give you diarrhea. Remember, all the enterocytes and all those intestinal cells are damaged, they shed off, and there's no absorption, and there is diarrhea. The next system to get involved is your cardiovascular system, guys. Okay, it can also lead to circulatory collapse. And the last system to get involved is CNS. Like I said, the most radio resistant cell is the neuron. So obviously the CNS system will be affected last, okay, at a very high level of exposure, at a very high dose. Guys, we're going a little fast because we have to touch upon a lot of topics. We have to cover almost everything. Okay, right? So types of radiations, again, ionizing radiations, X-ray, CT, PET, I guess we all know that. Non-ionizing radiations are USG and MRI. Therefore, they are safe in pregnancy, guys. Remember, ionizing radiations are not used in pregnancy. Non-ionizing radiations like USG and MRI are used in pregnancies. Okay, correct. Yes, so how many questions can we expect? Okay, so we can expect around 12 to 15 questions. That is the usual norm. Okay, guys, and trust me, you can get all of them correct. You can get all of them correct. Okay, and we are going to study them in an integrated manner, right? Okay. So basics of modalities, guys. This is how you should remember. CT scan is the elder brother of X-ray. Uses electrons, the metal is tungsten, and room is lined by lead. That's all you need to know, basics. Okay, so this is a CT machine. This is a CT machine, we all know. Okay, the room, the surrounding room in which this CT machine is kept, it is lined by lead. It is lined by lead. The metal that is used to generate these electrons is tungsten. Okay, CT is nothing but it is an elder brother of X-ray. Okay, so look at this, guys. Look at this. The first set of real images in radiology, right? Okay, so what appears white on X-ray is known as radio opaque. Okay, guys, can you see all of this? Can you see this hard shadow? Can you see this below the diaphragm? Can you see the bones, guys? Bones. Okay, all of this is white on X-ray, known as radio opaque. Okay, all of these shadows, you can see, guys, the air in the lungs. This is black. This is known as radio lucent on an X-ray. This here is the CT scan. How do I identify the CT scan? Guys, there's one point that you need to know to identify CT scan. Just look at the bones. Just look at the bones, guys, the vertebra here. What do you see the vertebra is? The vertebra is absolutely white. Okay, this white area, the whiteness on a CT scan is known as hyperdensity. It is hyperdense. Okay, and all of the black part, that is the air in the lungs. This is air in the lungs. The black part, this is known as hypodense. Hyper means more, hypo means less. Dense, dense. If it is white, it is dense. Hyperdense. If it is black, it is hypodense. On an X-ray, it is radio opaque or radio lucent. Okay, these are the basic terms, guys. Basic terms, just to get them out of the way. Hounsfield scale. Okay, there's only two values that you need to remember. Two values that you need to remember. Number one is water. Water is 0. Water is 0 means it appears like this, slightly grayish. Okay, slightly grayish on a CT scan. Remember, Hounsfield unit is for CT scan. Water is 0. Okay, cortical bone is 1000, guys, plus 1000, and air is minus 1000. Just these three values you need to remember, guys. Okay, apart from this, I don't think anyone will ask you anymore. So water is 0. Okay, cortical bone, or you can have any metal objects, which is plus 1000, and air is minus 1000. Okay, okay, now look at this. Look at this, guys. What is this? Tell me, come on, in the comment section. What is this? Is this a CT scan or is this an MRI? Come on, guys. I'm waiting for your answer. Yes, what is this? Come on. This has to be a two-way communication, guys. This is for you. You have to do it for yourself. Come on, tell me. Yes. What is this? Is it a CT scan or is it an MRI? Come on. Okay. CT, MRI. Okay, great. So all those who said CT scan, okay, I told you guys, the way to identify CT scan is to look at the bones, guys. The bones are absolutely white here. Bones are absolutely white, okay? This is a CT scan. This is a CT scan. Now I'll show you all the Hounsfield intensities here. Look at this, guys. Look at this. Do you see this bone is absolutely white? So I give this a value of plus 1000. Okay, plus 1000. Guys, look at the surrounding tissue, guys. Look at the surrounding tissue. Pitch black. Okay, it is absolutely pitch black. This has a value of minus 1000, guys. Minus 1000. And that is what you represent air with. Look at this, guys. Look at this. What do you see inside? What do you see inside? This is a ventricle. The ventricles have CSF inside. CSF is nothing but water. What do you think the Hounsfield of water is, guys? Yes. What is the Hounsfield of water? It is 0, guys. It is 0. So this is CSF and this is the water density. This is the water density. And one more brownie point, one step above what others know is, if you know this, guys, what is this? Come on. I'm waiting for your answers. Yes, come on. What is this? What is this lesion, guys? What is this lesion? Anyone has any idea about this lesion? What is it? Okay. What is it? Yes, it is infarct. Not really an infarct, guys. Come on. Subarachnoid hemorrhage, tumor. Okay, calcification. Okay, guys, let's just begin from the basics. Okay, what is it? Is it white or is it black? It is white. It is hyperdense. Okay, hyperdense. It cannot be on the air side of the spectrum. It has to be above water. Something that is above water and between bone. Less than bone, more than water. What do you think that is, guys? What do you think in our body is a fluid, is a liquid, which is above water but less dense than bone? It has to be, yes, absolutely right, hemorrhage. Yes, Spartan the Great. Yes, it is hemorrhage. It is blood, guys. It is blood. Okay, so this is how we use the basics, guys. We just know what color, what substance looks. Bone, absolutely white. Air, absolutely black. Water or CSF is 0. It has to be grayish. Okay, if anything is towards the whiter side, it has to be something more than water but less than bone. And in a body, it is one thing, and that is blood. So this is a hemorrhage, guys. This is hemorrhage. Okay, right. Let's move on. Yes. Okay, simple mnemonic here, guys. This is a very simple mnemonic that I've created for you, that NCCT is the investigation of choice. If a question comes in the exam, that if any of these are given and the question is what is the investigation of choice, blindly you can mark the answer as NCCT. Okay, so what is this? First C stands for, yes, to look for any calcification, guys. Any calcification, the first answer has to be NCCT. NCCT brain, NCCT, CT scan of abdomen, CT scan, wherever. CT scan is the first choice to look for calcification. Okay, the second one is a calculus, guys. A calculus. Stone. Okay, stone. So let's begin. Kidney stones, investigation of choice. Yes, guys, come on. Kidney stones, investigation of choice. Yes, CT scan. Come on. Give me the answers, guys. Give me the answers. Kidney stone, investigation of choice. Come on. I'm waiting. Kidney stones, investigation of choice. Yes. Kidney stones, investigation of choice is NCCT. Yes, that is absolutely correct. Okay, guys. Salivary gland stones or salivary gland stones, salivary duct stones. Investigation of choice. Come on, it is a calculus. Investigation of choice for salivary gland or salivary duct stones. Yes, yes, it is. It is. Yes, it is CT. It is CT scan, a non-contrast CT scan. Guys, investigation of choice in a urinary bladder stone. Urinary bladder stone. Come on, come on. Urinary bladder stone. Yes, yes, it is. Again, NCCT scan. And the last question, guys. Investigation of choice in a gallstone. Gallstone. Investigation of choice in a gallstone. In a gallstone. Yes, in a gallstone, it is USG, it is sonography, it is not NCCT, please remember. Calcification, calculus, all calculi except for gallstones. Investigation of choice is CT. In gallstones, investigation of choice is USG. Okay, okay. So calculus and cortical breaks. What are cortical breaks, guys? Cortical breaks means nothing but fractures. Okay, fractures. Like I said, bone has a Hounsfield unit of plus 1000, guys. We can see an absolute white bone. So any breaks are easily picked up in a CT scan. So any cortical fractures, investigation of choice has to be a CT scan. And the last one, T stands for trauma, guys. T stands for trauma. Okay. Yes. Any trauma. The answer has to be first investigation of your choice has to be your CT scan. Again, guys, one more very important. Investigation of choice in a metallic foreign body. Is again CT scan. Okay, CT scan. Can you tell me what is the contraindication? Which investigation is contraindicated in a metallic foreign body? Which investigation is contraindicated in a metallic foreign body? And this has been asked. Okay, so there is a request to take it in a bit of English. Okay, I'll try to take it in English. Okay, see, the main point is here so that everyone understands, everyone takes home the most important. Yes, very good. Yes, it is MRI. MRI is an absolute contraindication to metallic foreign body. Why? MRI, the word itself has magnet. There is a metal. If you use a magnet to detect metal, it will just pierce through. It will attract the metal. It will rip everything in its part. Do you want that? No. So there was a question in the exam. Okay, there was a person walking with a hammer and chisel, and a metallic object just flew into the eye. Okay, it went into the eye. Which of the following investigations will you not do? The answer was MRI. MRI cannot be done. The investigation of choice has to be CT scan. Okay, guys, let's move on. Okay, so let's take a look at this, guys. A very basic thing, but a very important thing that is asked in your exams, a very important that you face practically. Chest X-ray, PA view versus AP view. Okay, PA view versus AP view. Now remember, guys, in PA view, what are the important points to remember? That it is done in a standing position. Okay, fine. PA view, posterior anterior, means if this is the person, if I'm standing, then from behind, the rays will come from behind and I have a plate in front. Okay, this is the posterior anterior view. AP view means the rays are coming from front and going behind. This is the AP view or anterior posterior view. Okay, guys, what is the problem with AP view? Why don't we do an AP view? AP view we don't do because of false cardiomegaly, guys. False cardiomegaly, therefore we do not prefer AP view. In which patients would you like to do an AP view? In ones who cannot get a PA view done. Neonates, bedridden, trauma, ICU, unconscious. You cannot ask an unconscious patient to stand and get a PA view done, right? So in these patients, in ICU patients, in bedridden patients, in neonates, we get an AP view done, okay? Because something is better than nothing. So we need to look at what's there on an AP view, okay? But always PA view is preferred over an AP view. Can you see the heart size here is normal and the heart size here? Yes. Look at this, guys. So this is a cardiomegaly. Can you look at the ratio? See, thoracic ratio is here, but look at this, okay? So can you see the amount of width that the heart shadow is occupying in an AP view? It is more. It is falsely enlarged. It is false cardiomegaly. Okay, right. Okay, let's go further. Yes, this is the lateral view, guys. Lateral means from the side. So I'm standing like this and the rays are coming from the side. Remember, guys, lateral view, this is the X-ray that you will see, lateral view. Moving on, lateral decubitus. Decubitus means I'm lying on one side and the rays are coming from top. Lateral view, I'm standing, rays from side. Lateral decubitus, I'm lying on one side and the rays are coming from top. Okay, so this is lateral view and this is lateral decubitus, means I'm lying down on one side and the rays are coming from top. This is lateral decubitus. Remember guys, I'm telling you one point now and I'll ask you about it later also. Remember this very important point. Lateral decubitus view is the most sensitive view in X-ray to detect pleural effusion. I'll repeat myself. Lateral decubitus view in X-ray is the most sensitive view in X-ray to detect pleural effusion. Okay, remember this. I'll ask you again later. Moving on, guys. Moving on. See, like we said, PA view, what we do is we ask the person to inspire and hold the breath. Hold the breath. So we do an end inspiratory film, guys. At the end of inspiration, we send the radiations, the X-rays. But sometimes, in some conditions, we take an end expiratory film. Means we ask the person to exhale, and at the end of exhalation, we send the rays. Okay, this is known as end expiratory film, guys. Okay. Yes. So end expiratory film is done in these three conditions, guys. Pneumothorax. Okay. Yes, pneumothorax, air trapping, and diaphragmatic palsy. Remember, air trapping is very commonly seen in a condition known as COPD, guys. COPD, obstructive airway disease. Okay, chronic obstructive pulmonary disease, obstructive airway disease, COPD, air trapping is very common. Okay, so in these conditions, whenever we want to see if there is any air that is trapped, so what you need to do is normally whatever air you take in, you need to send it out by exhalation. Whatever remains behind is a pathological air. So to determine pathological air in the pleural cavity, it is pneumothorax. In the lung parenchyma, it is COPD. Okay, and also in diaphragmatic palsy, because diaphragm moves with respiration. Okay, on inspiration it goes down, and expiration it comes up. So if there is decreased movement of diaphragm and diaphragmatic palsy, for that also we need an end expiratory film of X-ray. Right. USG, guys. Basics about USG. One-liners can be asked very commonly. Okay, USG means ultrasound. Ultrasound, we know from our basic physics. Okay, the frequency of sound that we listen to, that we can hear, is 20 hertz to 20,000 hertz. 20 hertz to 20 kilohertz. Okay, so 20,000 hertz. Above that is ultrasound. So we use a frequency of more than 20,000 hertz or more than 20 kilohertz. That is ultrasound. It is produced by vibrating piezoelectric crystals, and it is made up of lead zirconate titanate. Okay, lead zirconate titanate. Okay, moving on to the ultrasound probes. Okay, guys, this images and these frequencies. Okay, this has also been asked. Okay. Okay. Yes, yes. Come on, guys. Let's focus here. Okay. Let's focus. Okay. English, Hindi, everything is fine. Okay. I'll try to teach in both. Okay. I'll try to teach in English as well as Hindi. Okay. दोनों में मैं बता सकता हूँ. Okay. So all those we'll try to just minimize the time used. Okay. Try to get the maximum out of the time that we have. Okay, guys. So please focus. Don't get distracted. Okay. Please focus on radiology, guys. This is important. This is for you. Like I said, the competition is not with others. The competition is with yourself. At the end of this lecture, you have to be more knowledgeable in radiology. Come on, guys, focus here. Right. So first probe is a pencil probe, guys. Pencil probe, a simple pencil probe. Okay, it is like this, a pencil probe. Minimum frequency used for transcranial Doppler. Okay, transcranial Doppler in children. Right. Okay. So the next one is a curvilinear probe, guys. A curvilinear probe. This is one of the most commonly used. Okay. So if someone asks you what is the most commonly used probe, it is a curvilinear probe, guys. Most curvilinear probe. 3 to 5 megahertz is the frequency used for abdominal and obs and gynae scans. Abdominal and obs and gynae scans. The USG A+P that we recommend usually, abdomen and pelvis, all of these use the curvilinear probe, guys. Okay, the linear probe. Okay, see, the curvilinear means there is a curve here. Can you see? Yes, the linear probe means there is a straight line at the end of the probe. This is a linear probe. Linear probe is for superficial structures like thyroid, USG neck, USG thyroid, USG breast. Okay, so this is a linear probe. And the last one is an endoluminal probe, guys. Endoluminal. Endo means inside or within. Luminal means a lumen. So within a lumen, we put a probe. That is endoluminal probe. So what are the lumens, guys? Okay. So esophagus, oral cavity. Transesophageal echo. Transesophageal echo. In rectal, okay, transrectal, okay, guys, in prostate cancer, we do a truss-guided biopsy. That is transrectal ultrasound-guided biopsy. There we use an endoluminal probe, okay. And the last one is transvaginal, that the TVS that we do very commonly in the gynae patients, in obs patients, TVS, transvaginal sonography. So all these are natural orifices, natural lumens. We introduce the probe inside, endoluminal, okay, transrectal, transvaginal, and transesophageal echo. These are the common examples. Okay. Now, guys, one important point that you need to remember. One point that helped me score marks in my exams. This simple thing, guys, this simple thing. CAT creates a fuss. This is my mnemonic that I have made. CAT creates a fuss. It means CAT stands for CT scan. Okay, the C and T stand for CT scan. That is best to detect air. So air is the best friend of CT scan, remember. And CAT creates a fuss. Ultrasound, US means ultrasound and F means fluid, guys. Okay, fluid. Come on, guys, focus here, please focus here. Okay, so CAT fuss. CAT means CT scan, air, and ultrasound, fluid. Okay, so the best to detect air. Look at this, guys. Look at this. What is this? The very pitch black, like I said, minus 1000 Hounsfield units. What is it, guys? What is it? It is air. It is nothing but air. And this is a CT scan. How do I know? Look at the bones. Look at the bones. Look at the bones, guys. Okay, it is white. It is absolutely white. So this is a CT scan and it shows air minus 1000 Hounsfield units. Now on the other side, this is a USG, guys. This is a USG. Look at this. This is the liver, guys. This is the liver and this is your kidney. This is your liver and this is your kidney. Liver is on the right side, obviously. So this is the right hepatorenal pouch. Kidney and liver, hepatorenal. So right hepatorenal pouch, also known as the Morrison's pouch, also known as the, yes, Morrison's pouch. So we see for fluid here. Okay, guys, what is fluid? Which fluid can be there? Okay, it is usually blood. So to look for blood, okay, this investigation is usually a part of what we do, EFAST. Okay, so in a patient of blunt abdominal trauma, a patient who comes to you with blunt abdominal trauma, you subject him to an EFAST. EFAST is nothing but an extended fast and ultrasound, a sonography to look for what? To look for fluid. Why? Because fluid is the best friend of ultrasound. Fluid, what fluid can be there? It can be blood. Okay, so this is an EFAST positive. Okay, this fast is positive. Why? Because we can see this pitch black fluid here. We can see the fluid between the liver and the kidney on the right side in the Morrison's pouch, and this is a fast positive. The fluid is the best friend of ultrasound and air is the best friend of CT scan. Moving on. Okay, so what fluids can be there, guys? What fluids can be there? Okay, pleural, pericardial, ascitic, any fluid you want to see, any fluid anywhere, you need to do an ultrasound first. You need to do an ultrasound first. Like I said, cholelithiasis, it means gallbladder stones. Like I said, investigative choice for all the stones is NCCT, except for gallbladder stones. In GB stones, the investigative choice is ultrasound. It is a USG, acute cholecystitis and a polyp. Okay, so gallbladder stone and a gallbladder polyp, they look very similar on a USG. How to differentiate between those two using 1 or 2 points? We'll come to that when we come to your systemic radiology in a few moments. Okay, after some time we'll look at those images also. Okay, in pregnancy, like I said, guys, TVS, transvaginal ultrasound, using an endoluminal probe. Endoluminal probe. Does anyone remember what was the frequency? What was the frequency of an endoluminal probe? Come on, guys, tell me. I'm looking at it. Come on. Yes, come on, tell me. What was the frequency of an endoluminal probe, guys? Come on. Yes. Okay. Veins. Okay, so varicose veins. In varicose veins, we do an ultrasound. We do a lower limb Doppler study. Okay, varicose veins, DVT, venous pathologies, we do a Doppler study. Doppler is nothing but an ultrasound. And a very interesting question that is being asked is the Mickey Mouse sign, guys. Mickey Mouse sign. Okay, Mickey Mouse sign. That is your great saphenous vein, common femoral vein, and a common femoral artery. These three form the Mickey Mouse sign. That is the 2 ears and the face of the Mickey Mouse. Face is formed by the common femoral vein. Okay, this is the GSV and this is the common femoral artery. Remember, guys, if you look at the anatomy, okay, this is the leg region and this is the groin. Okay, we know that from medial to lateral, the arrangement is vein. Okay, the arrangement is artery and the arrangement is nerve. Okay, so the femoral vein, medial, femoral artery, and femoral nerve. We know that the GSV, the great saphenous vein, comes from below and it drains into your femoral vein. So this part, see, guys, the GSV, the common femoral vein, and the common femoral artery, this junction here, this represents the Mickey Mouse sign. Okay, basic anatomy, basic on a USG, guys. Okay, yes. Come on, guys, keep it simple. Yes. Okay, so this is about your ultrasound, and the last one is an artery. In arterial investigations, remember what we do first is a Doppler, a color Doppler. Guys, color Doppler also gives us the direction of flow. It tells us about what the flow is like, where is it going. Okay, we have seen the red and the blue gradients, okay, on a color Doppler. Okay, so the first investigation in any arterial disorder, guys, for example, let's take thromboangiitis obliterans or the Burgess disease, commonly seen in smokers in the lower limbs, right? We get claudication. You've read this in surgery, right? Claudication in Burgess disease. What is the first investigation you do? First investigation you do is a Doppler. Okay, what is the investigation of choice? It is CT angio. CT angiography. What is the gold standard? Is DSA. DSA is the best gold standard. If it is the best, then why don't we do it first? If it is the best, then why don't we do it first? Why isn't the only investigation that is done? Come on, tell me. Okay, tell me, if DSA is the best, why don't we do it first? Come on, tell me, guys. I'm waiting for your answers. If DSA is the best investigation, why don't we do it first? Come on, guys, I'm waiting for your answer. Yes, come on, quickly. Okay, come on. Yes, because it is invasive. That is why we don't do it. We always prefer a non-invasive investigation over an invasive investigation. So DSA is gold standard, but it is invasive, therefore it is not done. Okay, CT angio is non-invasive, Doppler is obviously non-invasive, right? Okay, so coming to some USG images, guys, let's just use the basic concepts. What have we learned so far? CAT, pus. Remember CAT, pus. Fluid is friend of ultrasound, air is friend of CT. Let's use that. Look at this, guys. Look at this structure. Can you see a pitch black inside? This is an ultrasound. What do you think is anechoic or pitch black on ultrasound? It has to be fluid, guys. It has to be fluid. What is the fluid? What is the structure? What is the structure that you see? It is nothing but gallbladder, and the fluid inside is nothing but bile. This is a normal gallbladder, guys. Normal gallbladder. Okay, right. So gallstones. Okay, guys, gallstones, like I said, what will happen is, this is the gallbladder. Okay, you see normal black because of bile, and somewhere in between you will see white shadows. White. Why? Because gallstones are solid. They are not fluid. They are not liquid. Therefore, they will not appear black. They will appear white. Okay, and they'll cast a shadow. We look at it again, guys. We look at it again, and this is nothing but gallstones. Gallstones. Okay, look at this, guys. Look at this. This is what I was talking about. This is nothing but, yes, this looks like gallstone. This can be gallstone, but is it? The answer is no. Why? Because we don't see any posterior shadowing. Look at this, guys. Look at this carefully. Look at this carefully. Do you see a white area here? Yes, this is a gallstone. How do I know it? Because posteriorly, it is casting a black shadow. I'll erase this so you can see it again. Okay, I'll erase this so you can see it again. Look at this, guys. This is gallstone. Compare it now. Compare it with a polyp. Guys. Compare to the polyp. Okay, polyp. Look at this. Yes, in polyp you can see the white structure, but do you see any shadows? Do you see any shadows here? Any shadows? No shadows. So this is a polyp. This is not a gallstone. This is a polyp. Yes. What is this, guys? Come on. Any idea? Any idea? Just use the basics that I've given you. Just use the basics, and this I'll tell you. I'll give you a hint. This is a kidney. This is kidney. What do you see in a kidney? What is this? Okay, tell me one thing. Is it fluid or is it solid? Is it a fluid or is it solid? Come on. Is it fluid or is it solid? Yes. Dr. Ibn Farooq, very good. This is nothing but a simple cyst. This is simple renal cyst, guys. Simple renal cyst. And look at this, guys. Okay, all of this is fluid. What is the organ in the pelvis that holds so much fluid? This fluid is nothing but urine, and this organ is nothing but urinary bladder. And all these are normal findings, right? This is just to drive home the point that fluid is friend of ultrasound and appears black on an ultrasound, right? Look at this, guys. Look at this again. A pathology. You can see this black. This is fluid. Inside all these vesicles, you see black. All these are fluids. All these are multiple cysts. Which disorder shows multiple cysts? If I tell you that this is the liver, or if I tell you that this is the lung, what comes to your mind first? Guys? So many cysts. Yes, fluid filled cyst. What is this? Yes, what comes to your mind first is a hydrated cyst, guys. A hydrated cyst. Okay, a hydrated cyst. Okay, right. So modes on an ultrasound. Okay, this is just for your knowledge. You need to know the 3 modes: brightness, motion, and amplitude mode. Okay, we do not go much into that. Let's talk about the basics of MRI, guys. Basics. We can solve a lot of questions only from the basics, guys. Just get the basics right. Okay, MRI. Okay, this is an MRI machine, and this room that you see, this is Faraday's cage. It is lined by Faraday's cage. Okay, so that the magnetic strength, the magnetic field doesn't come outside the room. Okay, this is Faraday's cage. Look at this, guys. This is an MRI brain. Guys. This is an MRI brain. Okay, look at this, guys. A lot of people might think that this is the cortex, this is the cortical bone, this is the skull, and this is a CT scan. But please don't get confused. This is not the cortical bone. This is not the skull. This is the scalp fat which appears white. Okay, scalp fat which appears white. Okay, this is an MRI, guys. This is an MRI. This view is known as your transverse view or the axial view. This is your transverse view or the axial view. Hey guys, this is your coronal view, guys. This is your coronal view, and this is your sagittal view along the sagittal plane or the mid sagittal view. Okay, so sagittal plane is like this. So if I cut from the center, I'll have to look at it from the side. This is your sagittal view. Coronal plane is like this. It is horizontal. So if I cut from here and I look from the front, this is what I get, and this is the coronal view. And if I cut like this horizontally, if I cut through and through and look from above, this is what I get. This is the axial or the transverse view, and this is MRI, guys. Okay, basics of MRI. Basics of MRI. Yes. Contraindications, guys. Contraindications, absolute and relative contraindications to MRI, very commonly asked. I told you about the first one. The question has already been asked on metallic foreign body. Which investigation is contraindicated? It is MRI. Others, anywhere where metal is involved, it is a contraindication to MRI. Okay, cardiac pacemakers, cochlear implants, CNS aneurysm clips. Okay, so you get berry aneurysms or all those aneurysms and you clip it. Okay, then you cannot do an MRI after that, because if it is made up of a ferromagnetic material, you just pull it and it'll rupture everything there. You cannot do an MRI. Okay, relative contraindications, claustrophobia. Means if the patient is put into an MRI machine, the patient gets very anxious. The patient is claustrophobic because of lack of space or less space. Okay, patient cannot bear it. That is a relative contraindication. And prosthetic heart valves are nowadays also relative contraindications. Okay, guys. Fixators in orthopedics, guys. In orthopedics, there are two types of fixators, guys. Internal fixators that we put inside, and external fixators that we apply externally. Remember, guys, internal fixators are safe and external fixators are contraindicated for MRI. Right. Okay. Again, our friend is back. Okay, our friend is back. This is the fourth time that he's here. Now, again, this friend will help us remember where all MRI is investigation of choice. If the question comes blindly with your eyes closed, mark the answer as MRI in investigation of choice. Okay, so what is the first one, guys? Yes, CNS. Starting from the head, CNS. Any CNS tumor, guys. Any CNS tumor, any CNS malignancy, any CNS infection, guys. Any CNS infection, any CNS tumor, any CNS infection, your answer has to be investigation of choice as MRI. Okay, MRI. Yes. Okay, along the spine, guys. Any neurogenic tumors, guys. Neurogenic tumors, any neurogenic tumors, tumors of the posterior mediastinum. Mark my words, remember my words, I'll ask you again. Tumors of the posterior mediastinum, any neurogenic tumors, investigation of choice, MRI. Okay, in the lungs, guys, here we have our lungs. Okay, which tumor is found in the apex of lung? Guys, come on. Which tumor is this? What is the name of the tumor? I've given you a very important clue. It is found usually at the apices of the lung. What tumor is that? What is the name of that tumor, guys? Come on. Yes, it is a Pancoast tumor. Beautiful. It is a Pancoast tumor. An investigation of choice in a Pancoast tumor. Yes. Investigation of choice in a Pancoast tumor, again, is an MRI. It is an MRI. Okay. Right. Okay. Again, coming to the limbs. Okay. So we have femur here. Okay. Excuse the drawing, please. This is a femur. Okay. In femur, in long bones or in any bones, if you want to look for stress fracture, remember, guys, in cortical breaks, in proper fractures, CT scan is an investigation of choice. In stress fractures, there are micro fractures which cannot be picked up on CT. Stress fracture means an abnormal bone is there on which you normally exert excessive workout is there, or excessive force is applied. Okay, excessive force is applied on a normal bone, and this leads to breaking or micro fractures in the bone. Normal bone, excessive force, excessive strength, micro fractures cannot be picked up on CT. But investigation of choice has to be MRI. And another problem of bones, another infection of bone, okay, which involves the bone marrow, guys. Come on, which infection of bone involves the bone marrow? Come on, keep the answers coming. Keep the answers coming. Come on. Which infection of bone involves the bone marrow? Yes, come on. Yes, come on. Which one? Come on. Okay, it is osteomyelitis, guys. It is osteomyelitis. Okay, so acute osteomyelitis, there is bone marrow edema, and we use MRI. Bonus question for anyone who can answer. Which sequence of MRI is used for bone marrow edema? We will come to that. We'll take a look. We'll study that again when we come to details of MRI. But I'm just asking you, which sequence, does anyone know which sequence of MRI is used for bone marrow edema and osteomyelitis? Please let me know. I'll be really happy with that person. Come on. Right. Okay, let's move on to contrast media. Okay, contrast media, guys. Again, on X-ray, we use barium and iodinated, CT iodinated. MRI, we all know, gadolinium and USG, guys. This is very important. On USG, we use microbubbles, guys, microbubbles. Okay. Yes. Which microbubbles, which gas? Come on, anyone, which gas it is? Yes. SF6. Okay. So SF6 gas is the contrast used for USG gas. Okay. Look at this, guys. This is the barium that I'm showing you. Come on, guys. I'm giving you 4 options. What is this? Is this barium swallow? Is this barium meal? Is this barium meal follow through? Or is this barium enema? Come on, guys. Anyone? What is this? Come on, let it come. Yes, let the answers come. Come on, guys. Answer, please. It is for you. Even if you don't know, even if you're wrong, just put it out there. Okay. See, I personally learn from my mistakes. If I say some wrong answer in front of everyone, and if people say, "Arey, nahi, you don't know anything, man. This is not the answer. This answer." Trust me, it helps me remember better. It helps me remember that, oh my God, I was wrong. I was humiliated. Now I'll never forget. Okay. So the point here is not humiliation, guys. The point here is you have to remember by hook or by crook. Okay. So tell me, guys, come on. Yes, this is a barium swallow. Very good. This is a barium swallow. Why? What do you see? You see the oropharynx, guys. Look at this. You see the oropharynx. You see the esophagus. See the oropharynx, and you see the esophagus. What else do you see? What is this? You see the gastroesophageal junction. So if you see only these 3 structures, this is a barium swallow. Yes, guys. Okay. Let's look at this. Barium swallow shows you 3 structures: oropharynx, esophagus. Okay, from top to bottom: oropharynx, esophagus, G junction. Okay, now our our car has stopped at G junction. Now, any investigation that is beyond this will show you what? Come on, what is the next logical step? What is the next organ in continuity, guys? It is stomach. So if I see stomach, guys, if I see the stomach, and if I see the duodenum, especially the first part, duodenum, see, this is a stomach, guys, and this is the small part is the duodenum, and this is the stomach. So if I see the stomach and if I see the duodenum, this is a nice meal that I've had. And this is a barium meal. Yes. Stomach and proximal duodenum is barium meal. Yes, wonderful, guys. Wonderful. Yes, wonderful. Barium meal. Yes. Keep the answers coming, guys. This is for you. Trust me. This is for you. Okay. Look at this, guys. Look at this. What is the next organ in sequence? It is nothing but your intestines, the small intestine. Okay. Small intestine. What is this, guys? Come on. Yes. What is this? This is a BMFT, guys. A barium meal follow through. Will show you what? Jejunum and ileum. This question was also asked, guys. Which of them is featureless? It means it doesn't show any features, and that is ileum. Jejunum has a feathery appearance. Ileum is featureless. Please remember, this is a PYQ. Lastly, guys. Last but not the least. What is this? Come on, guys. It is very easy. What is the only one left? Come on. Yes, what is this? Yes, beautiful. This is a barium enema. Can you see this beautiful colon? Okay, colon. What do you see in the colon? Can you see these hostrations, incomplete hostrations? Okay, so that is how you identify. Look at this, guys. Look at this. Incomplete hostrations. This is your barium enema, showing the colon with incomplete hostrations, guys. Okay. Moving on. What are the contraindications of barium? Now remember, as long as barium stays within the GI tract, it is safe. Hear me out again. As long as barium stays within the GI tract only, it is safe. If it goes anywhere outside, it is dangerous. Should not be done. So if I say there is a perforation in the GI system, in the GIT, will you use barium? Answer is no. Okay. If I tell you that there's a short bowel obstruction, the barium cannot move further, the barium is accumulating, the barium is there accumulating, do you think you will use barium? There is no pathway for the barium to come out. You've given barium orally, but there is no way for it to get out. Do you think you will give barium? No. Post-op patients, again, post-op patients usually have ileus and all of those things, so we don't give because it is an adynamic bowel obstruction, right? So we prefer not to give barium. And this is TEF. What is TEF? Come on, guys. Anyone? Very simple. Come on. Yes. Anyone? What is TEF? TEF. Yes, I told you one simple rule for barium. As long as it is within the GI tract, is safe. Perforation, don't give. If outflow is obstructed, small bowel obstruction, hepatic ileus post-op, don't give. TEF is tracheoesophageal fistula. Yes, because it will go into the trachea. It will go into trachea. As long as barium stays within the GIT, it is safe. Here it is going to trachea. Not safe. You will not give barium. Okay, guys. One very brief concept of IP ratio. Okay, the questions may be asked. Okay, one of the very legendary professors, he says that for any exam that you prepare, always prepare one step or one level above the exam. Okay, so that it gives you a head start. It gives you an advantage all above everyone else. So this is that point, guys. This is that point. One step above, which is one step above, but please pay attention. I'll simplify it very, very, very simple. You'll never forget, guys. Okay. Yes, Boerhaave syndrome. Okay, Boerhaave syndrome. Again, there is an esophageal perforation. The esophageal perforation. Okay. Usually the history will be an alcoholic. Then there is retching. Okay. All of this macular striate. Remember, guys, macular striate in Boerhaave syndrome. Okay. So there is esophageal perforation. There again, you will not give barium. You will not give barium. Okay. Very good, Anirudh. Okay. So IP ratio, guys, this is iodine to particle ratio. Remember, iodine to particle ratio. Okay, if I ask you the names of any two contrasts in the world, everyone will say gadolinium first. We all know gadolinium is an MRI contrast. Any other contrast? Okay, barium and iodinated contrast. We all know iodinated contrasts are very common. What contrast? We have no idea. We don't need to know. Iodinated, iodine helps me, we know. Contrast iodine. So iodine and there's some particle. This is known as the iodine particle ratio. Iodine has to be more, particle has to be less in the ratio. Simple funda, basic. Iodine has to be more, particle has to be less. Why? Because particle is osmotically active. So IP ratio. So in any ratio, if you see, guys, if you see a ratio, say 6:2, 3:1, 3:2, anything that comes first, okay, this is I ratio. This has to be more. And anything that is the second number, this is a P ratio. This has to be less. Okay. So remember, 6:2, 3:1, anything that comes first is iodine, comes second is particle ratio. Iodine has to be more, particle has to be less. So iodine is usually represented by 6 and 3. Okay, 6 and 3, and particle is usually by 2 and 1. So the best will be what, guys? The best will be what? Come on. The best will be highest iodine, which is 6, and lowest particle, which is 1. So 6:1 will be my best contrast, and it is a contrast of choice, especially if the renal function is deranged. This is iodixanol. Iodixanol is the contrast, which is the best contrast that I have. Okay, right. Isoosmolar. Why isoosmolar? Because the P, the one which is osmotically active, is very less. Okay, it is isoosmolar. Again, low osmolar, guys. Okay, this is non-ionic dimer. Remember, this is a simple trick. If you see 6, it is dimer. If you see 3, it is monomer. If you see 2, it is ionic. If you see 1, it is non-ionic. If you want to remember it this way, you can. But the point to take home from here is the best contrast, especially if deranged RFT is there, is iodixanol. It is an isoosmolar contrast, 6:1. And the most commonly used one is, yes, iohexol. Iohexol is the most commonly used contrast. Okay, iohexol, it is a non-ionic monomer. Right? Okay, iohexol is the most commonly used. Yes, very good. Yes, adverse reactions to these contrast. One very important thing that you need to know is CIN. CIN stands for contrast-induced nephropathy. Contrast-induced renal damage, contrast-induced nephropathy usually comes, see, this is 48, okay? 48 to 72 hours. Within 48 to 72 hours, what will happen is the serum creat will start to rise. It will rise by more than 0.5. So, for example, if the serum creat initially was 0.8, within 48 to 72 hours, it will rise, it will become, say, 1.3 or 1.4. So this has to make you think of contrast-induced nephropathy. Or the serum creat can rise by 25% of the initial value. Okay, so for example, say it was 1.0. Okay, and now it has become 1.5. How much is the increase? The increase is by 0.5, that is 50%, guys. Okay, so this also fits into the definition of contrast-induced nephropathy. What is the risk factor? A pre-existing CKD. If the kidneys are already damaged, do you think the risk of nephropathy will be high? Obviously. Okay, so what do? You do a renal function test before the contrast. If you see the creat is already deranged, you try to avoid all these contrast agents that are there. Okay, so what one clinical scenario can come, the next step or the higher level question can be, how do you manage this? Okay, what are the steps that you need to ensure? So the answer to those questions will be adequate hydration, guys. Adequate hydration. And which drug is commonly used? Okay, which drug is commonly used? It is NAC, N-acetylcysteine. Okay. USG contrast, like I said, micro bubbles, guys. What was the gas? What was the gas? Come on, tell me. I told you what was the gas used. Come on, tell me, guys, in the answer. What was the gas used? Come on, guys. Come on, quickly, guys. Come on, quickly. It was SF6. SF6. Okay, moving on. Again, MRI contrast, what is the bad thing that can happen? What is the adverse reaction that can occur? Okay, so in CKD patients, again, see, all of these contrasts are excreted through your kidneys. They can damage your kidneys. It can lead to something known as nephrogenic systemic fibrosis, guys. Nephrogenic systemic fibrosis. And again, a brownie point, a higher level point, which receptors are involved? It is a toll-like receptors 4 and 7. Okay, let's move on. Okay. Yes, so that completes, guys, that completes our general radiology, our basics. Now let's use these basics and let's move on and let's build on our systemic radiology, guys. Are you ready? Are you ready for systemic radiology? Yes, we'll start with thoracic radiology first. Come on, guys, come on, tell me, come on. Yes, we'll touch upon everything that we can in the given time slot that we have. Come on, guys. Ready for systemic radiology? Let's go. Come on, you need to keep your energies high, guys. Come on, keep your energies high. Keep replying, keep responding. This is for you. This is for you. Yes, let's go. Okay, look at this image, guys. Look at this beautiful image that I have for you. This is the basic radiological anatomy that you need to know. Not everything. I'll highlight what you need to know, guys. Okay. The question that was asked, it's which of these ribs is posterior and which is anterior. Okay. Remember, guys, the ribs that are most obviously seen. Look at this, guys. Okay, so these ribs are posterior ribs. Remember, these are your posterior ribs, guys. Okay, so where are the anterior ribs? Look at this, guys. Look at this. Can you see this one? Okay, can you see this one? Can you see this? Okay, so the ones that are coming downwards and forwards, these are your anterior ribs. Obviously, guys, the ribs start from behind. They go like this and they come in front, downwards and forwards. So if you want to see the anterior ribs, they'll go downwards and forwards. If you want to see the posterior ribs, they're going like this. Okay, it is simple. Okay, right. So you need to know about the heart borders also, guys. Okay, about the heart borders also. Okay, look at this. The left heart border. The first is aortic knuckle. The first structure making up the left heart border is aortic knuckle. It is very important, guys. Very important. This anatomy will help you solve a lot of questions, understand a lot of concepts. Please pay attention. The left heart border starts with your aortic knuckle. Then it moves down to your pulmonary trunk, the main pulmonary trunk or the left pulmonary artery. It can be any one of those. The pulmonary artery is the second structure. The third structure is the left atrial appendage. And the final structure is your left ventricle. Can you see this? Beautiful left heart border, guys? Left heart border. Okay, starting with the aortic knuckle, the pulmonary artery, the left atrial appendage, and the left ventricle. This is your left heart border. On the right side, what do you usually see, guys? Here, what do you think? Which is the major vein which drains into the right atrium from above? Which is the major vein which drains into the right atrium from above? Come on. Which is the major vein which drains into the right atrium, carrying all the blood from your head and neck, finally draining into the right atrium? Come on, guys. Come on. Yes, it is the SVC. Beautiful. It is the superior vena cava. This is your right atrium. Okay, this is your right atrium. Which is the vein which carries the blood from your GIT, and coming into the yes. Which is the vein which drains into the right atrium, coming from the bottom, from your abdomen? Which one is it? It is IVC. Beautiful. It is IVC. Yes. So the right heart border is formed by the superior vena cava, the right atrium, and the sorry about that. Okay. Yes. the superior vena cava and the right atrium and the inferior vena cava. Okay, yes, let's go. How do I identify the ribs, guys? How do I identify the ribs? Okay, so the posterior ribs and all of that. Yes, the superior vena cava, the right atrium, and the inferior vena cava. This makes up the right heart border. Okay, okay. Counting the ribs. Okay, if it is an end inspiratory film. Okay, look at this, guys. Look at me. I'm taking a deep inspiration. My diaphragm is flattened. It is down. So I see more ribs. More ribs posteriorly means more than 10 ribs posteriorly if I count, and more than 6 ribs anteriorly. If I see that, I can say that this is an end inspiratory film. Okay, if you need to know. If you need to know. Right. Okay, guys, CT scan. How to identify structures on a CT scan? Very important, guys. If you know this, trust me, if you know this, you will be able to understand everything in thoracic radiology. Guys, please pay attention. This is the most important part. The most important part. If you know what is normal, you can easily say what is abnormal. Okay, this structure. Okay, again, very basic. Why is this CT? Why is this CT? Guys, why is this CT? Come on, tell me, why is this a CT scan? Yes, beautiful. The cortical bones plus 1000 Hounsfield units. This is a CT scan. Very good. Okay, look at the vessel, guys. This is a vessel and this is a bone. The vessel is as bright as the bone. The vessel is as dense as the bone. So this has to be a contrast enhanced CT scan, guys. This is a contrast CT scan. Okay, a contrast CT scan. This vessel. Okay, look at this. What is the level? I'll try to look at me, everyone here. This is a CT scan at this level. Okay, so at this level, what is happening is my arch of aorta is coming. Okay, it is going behind and it is going down into my abdomen. This is what is happening first. Secondly, my trachea is coming, my esophagus is coming, and my superior vena cava is coming. Okay, so all of these structures can be seen. Look at this, guys. Ascending aorta. It is going from here. It will turn down posteriorly and then go down. So I'll also see a descending aorta. Simple. Ascending aorta comes from the front, goes behind and goes into your abdomen. Descending aorta can also be seen. What is the vein? Yes, guys, I told you, a big vein that drains in the right atrium coming from above. This is your superior vena cava. Look at this, guys. Look at this. Remember cat fuss. Cat fuss. CT scan. Air is friend of CT scan. What is pitch black? Pitch black is air. What are the air containing tubes in the chest? Guys, it is nothing but trachea. Trachea divides into bronchi. This is your right main stem bronchus. This is your left main stem bronchus. Okay, this is right and this is left main stem bronchus. Okay, right. What is this, guys? What is this pitch black? Pitch black, pitch black. Come on, what is this? What is this pitch black structure on either side of the heart, which has air? On either side of the heart, air. What is there? Come on, guys. What is all of this? What is all this black that you see? What is all this? Yes, it is the lungs, obviously. Yes, it is the lungs. It has air. It is black. You see how we're using basic concept, guys. Basic. Air is the best friend of CT scan. Pitch black. Anything you see pitch black on on a CT scan is there. Okay, right. Now, one more important structure that I would like you to see is this structure, guys. Yes, this structure. This structure, it has contrast. It is a vessel. Which vessel is there, guys? Which vessel originates from the heart along with the aorta? It is your pulmonary artery, guys. So this is the main pulmonary trunk. If you can see here, this is the main pulmonary trunk and it is dividing. It is dividing into this branch, which is going towards the right pulmonary artery, and this branch, which is your left pulmonary artery. Okay, correct? How to identify aorta? Again, okay, once again, let's go. Aorta is a vessel. Okay, this is a contrast enhanced scan, so the vessels will be white. Aorta, look at me. I'm going sideways. So aorta comes from the front. It takes the arch and it goes down. So if you see from the front, this is a section here. So from the front, if you see from the top, you will see ascending aorta. Okay, and if it is going down, then again you see this is a descending aorta posteriorly. Okay, aorta goes backwards and towards the left. Okay, so this is the central line. You will see that ascending aorta, it is coming from the front and right and going downwards and back towards the left. This is a descending aorta. Okay, it is very simple, guys, very simple. Going on. Yes, look at this, guys. Look at this, another very commonly asked question in your exams, the heart prosthetic valves on an X-ray. How do you identify which valve it is? Is it a mitral valve or the aortic valve? These are the most commonly asked ones. Okay, aortic or the mitral valve. What do you do? If you see an X-ray with a PA view, okay, say for example, if this is the PA view or the AP view, okay, PA view, what you do is simple. The left heart border, come on, the left heart border, guys. What is the left heart border made of? Come on, quickly, guys, quickly. We're running out of time. What is the left heart border made up of? All the structures. Come on, list it for me. List it from top to bottom. Yes, aortic knuckle. Come on, aortic knuckle. Yes, then left pulmonary artery. Come on, then yes, left atrial appendage and the left ventricle. All of these make up your left heart border. So look at this, guys. This is the left atrial appendage. This is left atrial appendage, and this is your angle between the heart and the diaphragm, known as the cardiophrenic angle. This is the right side, so right cardiophrenic angle. You draw a straight line. You draw a straight line from your left atrial appendage to the right cardiophrenic angle. Any valve that is above this, you can safely mark as aortic, and any valve which is below this, you can safely mark as mitral valve. A for aortic, A for above the line. Okay, mitral valve is below the line. Come on, guys, it's simple. Is it simple, guys? Are you understanding? Are you enjoying this? Come on, give me a thumbs up, guys. Come on, give me a thumbs up if you're understanding this. If this is simple, if I'm trying to make it very simple for you, if it is going through, come on, let me know. Yes, come on, let me know, guys. Yes. Okay, great. Come on, guys, you have to respond. Come on. Yes. Okay. Oh, this is the lateral view. Okay, this is the lateral X-ray. Lateral X-ray, what do you do? Okay, this is the, yes, this is your, you draw a line from the carina. This is the carina. Okay, this is the carina, and you draw it to the costophrenic angle. Okay, this is the diaphragm. Okay, this is the diaphragm. So you draw a line from here through the carina. Again, above the line is aortic, below the line is mitral, below the line is mitral, and that is about your heart valve's position. Look at this. Come on, guys, what is this? Come on, tell me, anyone. What is this? Anyone who can tell me what this is? It is an imaginary line. Spartan, it is an imaginary line that you draw on an X-ray. Okay? No, don't jump to cartilaginous, friend. Please don't. Yes. Okay, so there are two terms that you need to know. Two very important terms. Look at the heart shadow, guys. Look at the heart shadow. Where is the heart shadow? It is on the right. On the left, there is no heart. See, the heart is missing on the left. It is towards the right. Okay? Yes. Okay, so this is dextrocardia. The heart is on the right. Okay, guys, what is the difference between dextrocardia and situs inversus? Come on, anyone. Dextrocardia and situs inversus. Okay, so why exactly their line? See, to identify in exams, okay, to identify the position, it is such, the position of the aortic valve lies above that line. The position of the mitral valve lies below the line. Okay, it is just that we found out that if you draw an imaginary line through these 2 points, it is easy to identify, to differentiate between the two valves. That is it. Nothing else. Okay, this is a line. Above that, if you see a valve, aortic, below it is mitral. There's nothing more to it. Okay. Okay, so this is dextrocardia, guys, and look at this. Heart again is on the right side. What is the difference between these two images? Come on, guys. Come on, quickly. What is the difference between these two images? Yes, look at the gastric bubble. Look at the gastric bubble here. The gastric bubble means the stomach is also on the right. Here, look at the gastric bubble here. The gastric bubble is on the left. It means that in this image, in the top image, only the heart is on the right. This is dextrocardia. In the bottom image, the heart and the stomach is on the right, which means situs inversus, means along with the heart, something else, the stomach is also shifted towards the opposite side. And yes, an important point here is cartilaginous syndrome. Yes, an important syndrome here is cartilaginous syndrome. Anyone who can tell me the triad of cartilaginous syndrome? Come on. Come on. Anyone with the triad of cartilaginous syndrome? Come on. Cartilaginous syndrome triad. There is a triad. Come on. Yes, immotile cilia syndrome. You're right. Immotile cilia syndrome. Cartilaginous syndrome triad is, yes, situs inversus, bronchiectasis, and the third aspect of triad is, come on, guys. Yes. Infertility is usually a part of Young syndrome. It is known as Young syndrome. Infertility. It is sinusitis, recurrent sinusitis, bronchiectasis, and situs inversus. This is the classical triad of cartilaginous syndrome. Infertility can be seen, but the classical question that is asked is Young syndrome is associated with infertility. Okay. What is this, guys? What is this? Air under diaphragm. Yes, Jyoti. Yes, Jyoti. Very good. Jyoti Munshi. Very good. This is air under diaphragm. Can you see? Air under diaphragm. Okay, air under diaphragm. What is this, guys? Air under diaphragm. Where is it seen? Where is air under diaphragm seen? Come on. Air under diaphragm is seen where? Ulnar diaphragm is seen in which condition, guys? Ulnar diaphragm. Also, another very important question, guys, that I was asked in my practicals, and a very important practical point, guys. Where do you see ulnar diaphragm? Do you see ulnar diaphragm on the right side, or do you see it on the left side? Where do you think it is more reliable? Where do you think it is more reliable? On the right side or on the left side? Come on, guys. Yes, pneumoperitoneum. Yes, perforation. Very good, very good, very good. Hollow viscous perforation is a perfect answer. Hollow viscous perforation is the perfect answer. Come on. Yes, you see it on the right side. Why not on the left side? Come on, simple, guys. Why not on the left side? Because on the left side, we already have an air-containing gastric bubble. It can give you a false interpretation. Okay, so we don't rely on the left side. We always rely on the right side where there's liver. Between the liver and diaphragm, there's never air. If there is air, it is always air in the diaphragm. It indicates hollow viscous perforation. Most commonly, it is bowel perforation. It is bowel perforation. Okay, guys. What is this angle? Come on. What is this angle? What is this angle, guys? Yes, it is very simple. Come on. Look at this angle. Tell me, I've given you a very important hint. It's an angle. What angle is this? Spotter. Yes, beautiful. It is a Cobb's angle. It is a Cobb's angle. So what you do is you take the top, the one which from where the deformity starts, the top, and where the deformity ends, the bottom. Okay, so you draw lines along those. Okay, then you draw perpendicular to those, perpendicular, and wherever they meet, whatever angle they create, that is a Cobb's angle. See, lines drawn. On the lines you draw perpendicular, and wherever they meet, whatever angle they create, that is a Cobb's angle. Okay, seen in scoliosis, guys. Look at this. Come on. Yes. What do you see, guys? What do you see here? Any abnormality that you can see here? Any abnormality that you can see here? Come on, come on. Yes, guys, keep answering. Come on, come on. What is the abnormality that you see in this? Can you see this shadow here of a rib that is coming? No, no, no. This is not steeple, guys. This is not steeple. Look at this. Look at this. I'll erase it so that you can see it again. Can you see this shadow, guys? Can you see this shadow? Yes, this is a cervical rib. Yes, this is a cervical rib. Why is it important? Why is it important? Because, guys, the subclavian arteries, the subclavian vessels, that is the thoracic outlet. The subclavian arteries go into your upper extremities through there. If there is a cervical rib, it blocks or it impinges upon your subclavian artery, and it causes something known as thoracic outlet syndrome. And this is an important point. Okay, look at this, guys. Look at this. Look at this. We knew that the right heart border is made up of SVC, right atrium, and IVC. Can you appreciate the right heart border, guys? It was supposed to be here. Can you see? Can you see the right heart border here? Can you see the right heart border, guys? Yes, this is a Silhouette sign. Beautiful. Yes, this is a Silhouette sign. The right heart border has been obscured. You cannot make out the right heart border. See, can you make out the left heart border? Yes, I can see the left heart border here. Can I make out the right heart border? No. Is it here? Is it here or is it here? I don't know where it is. This is known as the Silhouette sign. Silhouette sign. And this indicates pathology where? This indicates pathology in which lobe of the lung? Come on, guys, this is very important. Which lobe of the lung is involved if your right heart border cannot be seen? What is the lung site involved? It is your middle lobe, but to be more specific, it is a right middle lobe. It is the RML pathology or the right middle lobe pathology that you can see if your right heart border is obscured. Right. Okay. Yes. RML consolidation. Okay. So what I used to remember is RML consolidation. Basically, RML is CAP. That is seen in community acquired pneumonia. So community acquired pneumonia, the simple mnemonic that I remembered is consolidation. Okay, consolidation and something known as an air bronchogram sign. Air, yes, bronchogram sign. Okay, so this is seen in pneumonia. So CAP, community acquired pneumonia, very simple to remember. What are the features? Consolidation and air bronchogram sign. Moving on. Okay, look at this, guys. Look at this. What is this? What is this? Come on. Come on. All these are spotters, guys. All these are spotters. Let's just breeze through them. It is very important. It will come in your exam, and I'll tell you what will happen, how the question will be framed. Okay, so the question here is, what is this? The second question is, it is typically associated with which organism? Abscess? No, 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 it is not an abscess. Look carefully, look carefully. It is just an air-filled cyst. An air-filled cyst. Air means pneumo. Cyst means a seal. This is nothing but a pneumatocele. It is a pneumatocele. Remember, guys, it is a pneumatocele. Air-filled cyst, pneumatocele. This is usually associated with which organism? Which organism? It is not TB. No, no, no.
TB, there is proper cavity. Yes, yes, yes. Tranquil, Nirisha is the first correct answer is Staphylococcus aureus. Staph aureus pneumonia will give you pneumatocele. Pneumatocele is nothing but an air-filled cavity. Simple. Okay, moving on. Look at this, guys. Look at this. What do you see? What do you see? Come on. Is this again pneumatocele? Is this pneumatocele again? Come on, guys. What is this? Is this pneumatocele? What is this? Yes, yes, yes. Now you are right. Abdullah Sheikh, you are right. This is a lung abscess. Why is this not a pneumatocele? Why is this a lung abscess? Can you see this beautiful air fluid level? All of this is air and all of this is fluid. Okay, I'll use the eraser so that you can see again. Okay, look at this. Yes, can you see the air fluid level here, guys? Air fluid level, again, this is a lung abscess. So the typical history will be a patient has high grade fever, his counts have increased, and there is cough with purulent expectoration. Okay, the patient can be bed bound, the patient can have a chronic ailment. Okay, so all of these are pointers towards lung abscess. Okay, remember, chronic illnesses or elderly patients, high fever, raised counts, and cough with purulent sputum, with purulent expectoration, always think of a lung abscess. Moving on. Okay, look at this. Okay, so the history here is, guys, that this is a patient who is alcoholic. This patient is alcoholic, and the typical cough with expectoration that you get here is a red currant jelly sputum. A red currant jelly sputum in an alcoholic patient. This is your X-ray. This can be only one thing, guys. This can be only one thing in your exams, and this has to be what? Come on, come on. What is this? Come on, join the dots, everyone. Come on. Everyone who's here, give it a try. Yes, 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 yes. You're right. This is the bulging fissure sign. This is the bulging fissure sign, and this is seen in Klebsiella pneumoniae pneumonia. Okay, Klebsiella pneumoniae is the organism, and this is a classical bulging fissure sign, alcoholic with red currant jelly sputum. Okay, look at this, guys. Look at this. What is this? What is this? Come on, tell me. Anyone who can tell me what this is? Come on. Yes, come on. I'll give you a hint. This was a patient who has had TB before. This is a patient who has had TB before. What is this? Okay, yes, yes. Vinay Kumar, yes, you are absolutely correct. This is a fungal ball. What happens is that a patient has TB. TB usually affects the apices of the lungs. Okay, so this let's arbitrarily say these are the apices, the apex of the lungs. There is cavity. Within this cavity, this aspergillus comes and resides, and it starts to grow. This is known as a fungal ball or an aspergilloma. A fungal ball or an aspergilloma. Okay, and you can see this black shadow. Okay, this black shadow. Can you see? I'll erase it so that you can see. Appreciate it again. Can you see this, guys? Can you see the black shadow? Okay, this is your. Which sign is this? Which sign is this, guys? Air crescent sign or monod sign. Okay, guys, come on. A pediatric child, high grade fever, respiratory distress. What is this X-ray? Come on, come on, come on. Yes, you're right. It is the monod sign. Yes, air crescent sign. Thumb sign, Zenker's diverticulum. No. This is not Zenker's diverticulum. Thumb sign is right. Yes, this is thumb sign of acute epiglottitis. Come on, guys. Yes, acute epiglottitis, thumb sign. Can you see this inflamed? Can you see this inflamed epiglottis? Yes, this is your thumb sign of acute epiglottitis. Again, yes, the very commonly asked question. What is this? Come on, guys, let's finish this. Let's finish thoracic radiology rapidly. What is this? Yes, this is a steeple sign. Steeple sign seen in. Come on, guys. Seen in which disease? Which condition? Steeple sign is seen in which condition? Yes. It is croup. Acute laryngotracheobronchitis. It is croup. Yes. Okay, look at this. Can anyone tell me what do you see? Can anyone tell me what do you see? I'll give you a hint. Look at this lesion here. And look at this lesion here. That is hint number 1. Hint number 2, it is one of the most common infections in India. Most common in India. Which infection do you think? Which infection comes to mind, guys? No. This is not METS. This is not METS. Infection, I'm giving you a hint. This is a patient who has presented to you with fever since 1 month, dry cough. Sometimes there is blood in sputum. There is unintentional weight loss over a period of 3 months. He has lost 10 kgs. 1 month fever history, 1 month cough history, with sometimes blood streak sputum. He has lost a lot of weight. He is cachexic. What do you think this is? This is very classical of TB, guys. This is very classical of pulmonary cox. Okay. Bonus question, a higher level question. Which stage of pulmonary cox is this? Which stage, guys? Which stage? This is known as primary TB, guys. This is primary TB. Primary TB. Yes, night increased fever in the night, evening rise of temperature. All these are features of TB. So this is how your question will be framed, and this is what you'll be given. This is primary TB. Why primary TB? You can see lymph nodes, guys. This is a hilar lymph nodes, and this is your parenchymal pathology. The lung parenchyma is involved, lymph nodes are involved. This forms a complex. This forms a complex. This is known as what? Okay, this is known as what complex? In the lungs, the TB forms a complex known as Ghon's complex. It is known as Ghon's complex, guys. It is known as, yes, GHON. It is a Ghon's complex. Okay, right. Okay, so you treat this patient. This patient comes to you, and then he's come to you again. He's come to you again after a few months, after 6 months, or after 1 year or 2 years, and this is his X-ray. What is this, guys? What is this? This is the sequelae of his primary TB. This is the sequelae. This is what happens. Okay. Yes. This session is enough for upcoming FMGE. This session is more than enough. Trust me, this is more than enough. Rapid. We'll complete everything rapidly. We'll use the basics to solve everything. Trust me. Okay. This patient has come to you after 2 months. What is this? After 6 months or 2 years? What is this? This is a sequelae of primary TB known as post-primary TB. What happens here, guys? Look at this. Look at this, guys. This is fibrosis. This is nothing but fibrosis, guys. Fibrosis means all of that is fibrosed. It means it is pulling all of this area. All of this area is dead, and there are fibrotic strands. They will pull. Look at the trachea, guys. Look at the trachea. How is the trachea going? Okay. Look at this fissure sign. Look how the lung fissure is also pulled up. All of this is fibrosis, and this is known as your post-primary TB. Post-primary TB, classical fibrosis scene. Okay. Yes, cavities is seen in primary TB. Yes. Okay. So cavity is seen in TB. Okay. So the lung parenchymal lesion that you saw here. Okay. Yes. The lung parenchymal lesion that you saw here. This will eventually turn into a cavity. This will eventually turn into a cavity. Okay. The TB loves the apices of the lungs. Why? Because TB Mycobacterium tuberculosis loves oxygen. The apices of the lung have maximum oxygen, the ventilation to perfusion ratio. Remember, guys, physiology, okay? Ventilation is maximum in the apices, oxygen concentration is maximum in the apices. Therefore, TB loves to stay in your apex and forms a cavity over there. Okay. Okay, guys, look at this. Finally, after 6 years or 7 years, he is not compliant with the medications. He has not taken medications. Now the same patient has come to you with this. What is this, guys? What is this? Come on. This is very easy. Come on, guys. What is this? Yes. Yes. Everyone. Yes. You're all right. You're all right. This is miliary TB. Look at these miliary lesions. This miliary lesion, 1 to 3 millimeter miliary lesions. Okay. It is not specific for TB, but since the history is there, he has come to you with primary TB, then post-primary TB. Now he's come to you with this lesion. It can be nothing else, but it has to be your miliary TB. Guys, so this is a sequence in which we study. This is the basics of how we study, guys. And in this way, you will never forget. You will never forget. You look at it, you know the case history, you know the patient has been a chronic patient, and this has to be nothing but miliary TB. Okay. Look at this, guys. Look at this. The answer is already there on your screen. But what I want you to answer, is this, guys. Is this. What is the investigation of choice in COVID-19? Come on. Investigation of choice in COVID-19. It is a very commonly asked question, guys. Come on. You are expected to know this, and a lot of people answer this wrong. Okay. A lot of people say, yes, HRCT. Okay. HRCT. Yes. Yes, come on. HRCT. Okay. Okay. Yes. Anirudh. Yes. Pyali Shinde. Yes, you are right. The answer of investigation of choice, guys, it cannot be HRCT. It has to be your RT-PCR, guys. Here, most of you all go wrong. Investigation of choice has to be RT-PCR. RT-PCR, guys. The imaging investigation of choice, here your answer will be HRCT chest. Guys, please don't mess this up. This is a very commonly tested area, a very, prone to confusion area. Investigation of choice, RT-PCR. In imaging investigation of choice, HRCT. Okay. Okay. Yes. Revise today itself. It will help you immensely, and beyond this, you don't need anything. Trust me. Okay. Yes, annotated PDF will be available. Okay. Right. So look at this. Now I've shown you very specific. Okay. So if the examiner wants to ask COVID imaging to you guys, this is what he will give you most likely, because this is very highly likely and very highly suggestive of COVID-19. This is known as the CORADS 5. Okay. The CORADS is the reporting and data system, the COVID reporting data system, which is there for HRCT. What you have to do is you have to look at the lesions. This is the CORADS 5. This is multiple, look at this, multiple peripheral bilateral GGOs. Multiple peripheral bilateral GGOs, ground glass opacities. This is very highly suggestive of COVID. Okay, this is CORADS 5. So the CORADS, okay, so 1, 2, 3, 4, 5, and 6. Okay, so this is a very highly likely suggestive of COVID-19, bilateral multiple ground glass opacities, peripheral. What is CORADS 6, guys? Come on. CORADS 6 is confirmatory. This is very highly likely, very highly suggestive. What is CORADS 6? CORADS 6 is confirmatory that this has to be COVID-19, nothing else. What do you think that is? What do you think CORADS 6 is? Come on, guys. What do you think CORADS 6 is? Which investigation is 100% confirmatory for COVID? Which one is that? CORADS 6 has to be. Which investigation, guys? Come on, the answer is right there on your screen. CORADS 6 has to be RT-PCR. RT-PCR is the confirmatory investigation and the investigation of choice, and CORADS 6 in COVID-19. Okay, guys, COVID-19. Okay, that's all you need to know for now. Hold on. Look at this, guys. Look at this. Okay, one more point. Okay, so what happens? What is a halo, guys? What is a halo? You've seen halo. Okay, so what happens is that there is a central opacity, and surrounding it you see a halo. This is the halo sign. Halo sign. What is reverse halo? Reverse halo means in center there is some opacity or lucency, and surrounding that there is opacity. Okay, exactly what you see here, guys. This is the reverse halo sign, guys. Reverse halo sign. Okay, also known as the atoll sign. Atoll sign. It is also seen in COVID-19, but it is also seen in COP. COP stands for cryptogenic organizing pneumonia. Yes. Yes. Tranquil, Nisha. Absolutely perfect. It is cryptogenic organizing pneumonia. Also shows you atoll sign or this crescent sign. Okay. Look at this, guys. Look at this. Look at this. What do you see? What do you see? Come on, quickly, guys. Quickly. This is for you. This is for you. This is very important. Very commonly asked. Very commonly asked. Come on, guys. What is this? What is this? What do you see here? Look, guys. Look at the costophrenic angles, guys. What is this? What is this? Blunting of costophrenic angles. What is this? Blunting of costophrenic angles. Come on, guys. This has to be only one thing. Only one thing has to come to your mind first. What is this? Come on, answer, guys. Come on. Whatever comes to mind, just say it, please. This is a safe space. Trust me. This is for you. Come on, tell me. Blunting of CP angle. Yes, pleural effusion. Beautiful. This is nothing but pleural effusion. Again, trick question. What is the most sensitive investigation for pleural effusion, guys? Come on. Yes, what is the most sensitive investigation for pleural effusion? Guys, do you remember the mnemonic? What mnemonic am I talking about? Pleural effusion is nothing but fluid. Yes, thoracic ultrasound. Beautiful. You guys are picking up. Absolutely amazing, Anirudh. Yes, Ibn Farooq. Yes, Nirisha. It is most sensitive investigation has to be your ultrasound. Most sensitive X-ray. Guys, I told you this at the beginning when I was showing you different views of X-ray. Most sensitive X-ray to pick up pleural effusion is most sensitive X-ray view. Which is X-ray view? Is it PA view? Is it? Yes, lateral decubitus X-ray. Yes, Anirudh. Yes, Ibn Farooq. Absolutely brilliant. It is lateral decubitus X-ray is the most sensitive X-ray. What is the earliest sign on X-ray? Come on, guys. Earliest sign on X-ray. You're looking at it here. What is the earliest sign on X-ray? Come on, guys. Earliest sign on X-ray. It has to be your blunting of CP angles. It is blunting of CP angles. Okay, so here there is some doubt, some confusion. Let me clear it. Most sensitive X-ray view is your lateral decubitus view. Okay, more than lateral view, more than PA view. This is the sequence in which you have to answer. Okay, confusion cleared once and for all. right? Okay. Look at this, guys. Look at this. What is this? Come on, what is this? What is this? What is this? What is this? Look at this. Look at this. What is this, guys? What is this? Can you see the CP angle? What is this, guys? Come on. Yes, this is also pleural effusion, guys. This is also pleural effusion. Okay? Come on. Yes, look at this. Look at this. Do you see an air fluid level? This is the fluid and this is the air. Air fluid level. Where do you see air fluid level? Come on, guys. Air fluid level is hydropneumothorax. Yes, Hussein Shakir. Brilliant. It is seen in hydropneumothorax. Okay. Guys, here. Okay, so what happens is that a person or a junior resident, okay, a doctor is inserting a central line. Okay, he's inserting a central line. Okay, while inserting the central line, the patient suddenly starts to collapse. Respiratory collapse, circulatory collapse. The patient goes into hypotension and shock. The saturation starts falling. You do an urgent X-ray, this is what you see. What are you guys thinking of? No, this is not hollow viscous. Yes, 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 yes. Anirudh, you're right. Yes, Mukesh, you're right. Pneumothorax. But guys, this is not just pneumothorax. I told you the patient was collapsing. The BP is falling. The saturation is falling. Can you see here? Can you make this out? This is the collapsed lung. Can you see the trachea is shifted? Can you see the mediastinum is shifted? This is not just pneumothorax, guys. This is tension pneumothorax. This is tension pneumothorax. Can be seen after trauma. Can be iatrogenic, like I said. A resident or any doctor inserting a central line. By mistake, you pierce the apex of the lung, of the right lung. Air enters into the pleural cavity, pushes this. The air, you see the right lung is collapsed. Guys, this is the right lung. Okay, normally it was supposed to be here. The air is filling and it is collapsed. The right lung. This is known as a visceral pleural line, guys. This is the visceral pleural line sign. And this is nothing but tension pneumothorax. What is the treatment, guys? What is the treatment? Yes, what is the treatment? Come on. What is the treatment of tension pneumothorax? Come on, guys. Yes, what is the treatment? I'm asking you. Spartan Great, come on, tell me. What is the treatment of tension pneumothorax? Patient is collapsing. Patient is dying. Saturation is falling. What will you do? There is air in the chest. Okay? Remember, any pathology anywhere in the world, any subject, any pathology, you treat the root cause, the pathology will go. Here the root cause is excessive air in the pleural cavity. Your treatment has to be to get that air out immediately, urgently. The answer is a wide bore needle insertion. Wide bore needle insertion so as to get all the air out. Where will you insert the needle? The next question is, where will you insert the needle? Where will you insert the needle? In a child? This is commonly asked. And where will you insert the needle? In an adult? Come on, guys. Come on, guys. Fast, fast. Come on, come on, come on, guys. Yes. In the second intercostal space. Yes. In the mid-clavicular line. Yes, absolutely beautiful, Nirisha. That is for children. Second ICS. In the mid-clavicular line. Yes. In adults, where? Adults, you will insert in the fifth intercostal space. Where? Fifth intercostal space. Where? Mid-clavicular? Mid-clavicular? No, not mid-clavicular. In adults, fifth intercostal space in the triangle of safety, guys. In the triangle of safety. Where is the triangle of safety? It is on the lateral aspect, guys. It is bounded anteriorly by your pectoralis major, posteriorly by your latissimus dorsi, and the base is formed by the rib. Okay, okay. Fifth rib. How do you insert the needle? You insert the needle from the upper border of the lower rib. Upper border of the lower rib. Okay, right. So this is all about tension pneumothorax. So once the air comes out, you insert an ICD, intercostal drain has to be put in. Okay, okay. Look at this, guys. This is also another important question that is asked. Okay, this is sonography, guys. This is M mode. I told you there are three modes of an ultrasound. Okay, brightness mode, amplitude mode, and the motion mode. This is the M mode here. You can see the motion. Look at the normal one first, guys. Look at the normal one. Normally, what happens is that the lungs move. See, this is the lung. The lungs move with respiration. The chest wall doesn't move as much. So chest wall remains kind of stationary. The lung moves. When the lung moves, it creates a disturbance. Can you see this dot, 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 dot? And this chest wall remains constant or stationary. So this gives an image of a beach meeting the sea. That is your seashore sign. Okay, beach meeting the sea, seashore sign. This is normal. What happens in pneumothorax, guys? What happens in pneumothorax? In pneumothorax, like I said, the lung is collapsed or there is air in the pleural cavity. The lung cannot move. The chest wall was stationary. The lung also becomes stationary. The chest wall was showing linear striations. The lung will also show linear striations. There is no beach-like granularity. The seashore sign is lost. And here what you see is a barcode or a stratosphere sign. Never forget, guys. Never forget. Seashore, guys, we've all been to the beach. We've all been to the seashore. It is a normal place. It is a normal finding. It is a normal phenomena. That is how you remember. Have you ever been to the stratosphere? Have you been to the atmosphere? Guys, you have not. So stratosphere, going to stratosphere is not normal. Going to the beach, a seashore is normal. And that is how you can remember. Simple. Okay? Right? Okay. So pneumothorax, again, guys, pneumothorax, what are these questions? What are these things that you need to know? What is the most common, most sensitive investigation on an X-ray? What do you see? Come on, guys. What do you think the answer is? Yes, most sensitive investigation. What is pneumothorax, guys? What is pneumothorax? Again, remember, guys, remember the mnemonic. Come on, remember the mnemonic. Remember the mnemonic. Remember the mnemonic. The most sensitive investigation. I've written the mnemonic for you guys. Pneumothorax is air in the pleural cavity. Which investigation is the best friend of air? Come on. I don't see any answers, guys. Come on. No, it is not ultrasound, guys. Remember cat fuss, air. The most sensitive investigation has to be a CT scan, guys. The most sensitive investigation has to be a CT scan. Come on, guys. You cannot forget this basics, right? Cat fuss. Remember this for the rest of your life. Any fluid, anywhere, you do an ultrasound. Air, anywhere you have to see. Pneumoperitoneum, pneumothorax, pneumocephalus. What do? You do a CT scan because air is the best friend of CT scan. Okay? Yes. No, Anil, no, sorry. Please, no, sorry. This is for you. This is a learning point for you. I have also learned it in a similar way. I've also given a lot of wrong answers, right? See, I am on this side, but still I haven't scored 100%. I don't know everything, but I just know a bit of everything. And that is all you need to know. All you need to remember are the basics. Okay, right. On X-ray, guys, which is the film that we take. Remember, I told you to see air trapping. Remember the pad, air trapping, diaphragmatic palsy, and P was for pneumothorax. Which film was it? Guys? It was the end expiratory film, guys. End expiratory X-ray is what we take. Okay, see how we're linking the basics, guys. See how we're linking everything that we learned in the basics and we're linking it now. Okay, moving on. Look at this, guys. Look at this. This is a mass. Okay, I'll just show it to you, show the answer. What this is? Thymoma. Okay, see, that's not significant. This is a thymoma image that I've given you. Okay, fine, this is thymoma. But what are the questions asked, guys? What is the most common mass in the anterior mediastinum? Come on, yes, the answer is right here. It is yes. See, forgetting after revision is absolutely normal, guys. Please normalize forgetting. We are human beings. We are bound to forget. We are made in that way that we forget. If you remember everything, then I don't think you're a human being. You're a machine. You are bound to forget. You need to revise. And even after that, you can forget. Even after understanding concepts, you can forget. It happens with me. It happens with everyone. It is absolutely normal to forget. All you need to do is keep your head down, revise, solve questions, forget, come back, revise, solve questions, forget, revise, solve it. That is the cycle. And eventually, you'll remember more than 80 to 90% of what you've read. And that is enough to crack the exam, that is enough to pass the FMGE exam, guys. Okay? Please don't think that you can remember everything. No one can, guys. Not even All India Rank 1 gets everything right. They don't. Okay? Come on. Yes. So, most common mass in anti-mediastinum is thymoma. Most common mass in middle mediastinum. Yes, guys. If it is usually a lymph node, guys. It is usually a lymph node in adults. In child, if they ask, you can say the answer is a foregut duplication cyst or a bronchogenic cyst. Okay, usually not asked, but still for information, if middle mediastinum mass in adults, it is usually a lymph node. Okay. Yes, posterior mediastinum, guys. Posterior mediastinum, I told you. This is the answer. I've already told you if you were listening. Guys. Neurogenic tumors are the most common mass in the posterior mediastinum. The investigation of choice for neurogenic tumors. Guys, come on. The answer to this is yes, neurogenic tumors. What is the investigation of choice for neurogenic tumors? Come on, guys, answer this. Come on, guys, you know it. Come on, fast. Come on, fast, rapidly, guys. What is the investigative choice for neurogenic tumors? It is an MRI. It is an MRI. It is an MRI. We already studied this, guys. It is an MRI. It is an MRI. Lung cancer's investigation of choice. One-liner. Lung cancer investigation of choice. Yes, Vinay Kumar, you are right. This is a contrast enhanced CT scan. Okay, this is a contrast enhanced CT scan. Except which lung tumor CT scan does not work. I told you guys. This again we've discussed. The tumor in the apex of the lung. Which lung tumor uses not MRI for its detection? The investigative choice is, sorry, it is not CT. The investigative choice is MRI. Investigative choice is MRI. For which tumor, guys? Which tumor? Come on. Come on. Yes, the pancreas tumor. Beautiful. Okay. See, everything is here. All your MCQ points are here. Okay. This is all you need to see before you go for exams, guys. All you need to see after this session to revise. Okay. Okay. Pneumomediastinum, guys. Look at this. Look at this. Pneumo means air. Pneumo means air. Mediastinum is, of course, the mediastinum where your heart resides. Okay. Antemedullary posterior mediastinum. Pneumomediastinum. What is the sign? Look at this, guys. What is the sign? What is the sign called? Do you see that the diaphragm has become continuous? There's a continuous air in the diaphragm. This is known as a continuous diaphragm sign. This is a sign of pneumomediastinum, air in the mediastinum. Okay, guys, do not confuse it with pneumoperitoneum. In pneumoperitoneum, you will see air in the diaphragm, but it will be on the right side only. Here you can see a continuous line, which is above the diaphragm. It is not below the diaphragm. Air under diaphragm means under the diaphragm, below diaphragm. Pneumomediastinum means air is above the diaphragm, below the heart. There's a continuous diaphragm sign. This is not hollow viscous. Please don't get confused. This is not hollow viscous. Okay. This is pneumomediastinum. Look at this. Look carefully, guys. Look carefully. Okay. Come on. Okay, guys. Come on. This is very easy. Very easy. Very commonly asked. What is this? Come on. What is this? What is this? Guys, come on. Esophageal foreign body. Absolutely right, Anirudh. This is an esophageal foreign body. But why do you say so? Why esophageal and why not trachea? Okay, so I've got a prop for you. Look at this. This is a coin. Look at this, guys. This is a coin. My esophagus is like this. It is horizontally. So if my coin has to go, it has to pass horizontally. If I look at my X-ray from the front, my coin will be like this, flat. This is coin in esophagus. If I look at the lateral film, my coin will be slit-like. This is coin or foreign body in esophagus. What happens in trachea? My trachea is slit-like, guys, because of the vocal cords. So the coin cannot pass like this. The coin cannot pass like this. The coin has to pass like this. So once it passes like this, in your AP view, I see the coin like this, slit-like. Okay. And my lateral view, I see the coin like this. Simple. Okay. So esophagus versus trachea. This, as you can see, is, yes, perfectly round. It means it has to pass through a horizontal slit. This is nothing but esophagus. A lateral film, as you can confirm. Look at this, guys. Look at this. Can you see the air-filled lining structure here? This is your trachea. The trachea is absolutely clear. The coin of the foreign body is behind the trachea, and this is your esophagus coin, foreign body in esophagus. Okay. Yes. Now look at this. Come on. This is foreign body trachea. Come on, guys. Absolutely no-brainer. The vocal cords are oriented like this. The coin has to pass vertically. The coin has to pass vertically to go into the trachea. Okay. Okay. The patient is symptomatic. Okay. If the most common site in esophagus, coin esophagus, where it is lodged, is the cricopharyngeal junction. Okay. So it can be taken out by esophagoscopy. Yes, it can be taken. It can be taken out by esophagoscopy. And if it is the trachea, it can be taken out by rigid bronchoscopy. Remember, guys, rigid bronchoscopy, not flexible. Right? Okay, one of the most dangerous, guys. This is the most dangerous thing that you can find in the esophagus or trachea. What is this, guys? What is this? Come on. Halo sign. Can you see this? Can you see this, guys? Can you see a halo? Can you see two round structures? Can you see the beveled edges, guys? Can you see the beveled edges? Can you see the beveled edges? What is this? Yes, this is a button battery, guys. This is a button battery. Button battery. Absolute emergency, has to be removed urgently. Okay. It is corrosive. Shift of mediastinum, just a very basic concept, guys. Remember, shift of mediastinum can be pull or can be push. If I'm pulling you, if I'm pushing you, you will go away from me. If I'm pulling you, you will come towards me. It is simple. What pushes? If there is a lot of fluid, a lot of air, like we saw in tension pneumothorax. It'll push away. What will pull? What will pull is collapse or fibrosis. Fibrosis means it's shrinking, so it will pull. And consolidation is just solidification. Okay, we've learned all the stages of pneumonia in our pathology. Okay, there are 4 stages. Remember, stage of red hybridization, gray hybridization, resolution, all of this. This is part of consolidation, and there is usually no mediastinal shift in consolidation. Yes, come on, guys. Come on, I've given you the hint, a biggest hint. Come on. What is this? What is this? Come on, guys. Come on. Yes. Tell me, what is this? Come on, come on, come on. Yes, yes, you're right, Anirudh. Come on, you're right. Come on. This is an Epstein's anomaly. What is a drug? What is a drug associated with Epstein's anomaly? Lithium. Lithium. Yes, you're absolutely right. Lithium. Lithium. Can you see the box-shaped heart? Okay. Next. Come on. We're breezing through, guys. Come on. We have to go through this rapidly. This has been seen and done a lot of times. You just need a quick revision of this and you will never get it wrong. Come on. What is this? Yes, this is TOF. Can anyone tell me what are the 4 components of TOF? Tetralogy, right? Tetra means 4. What are the 4 components of TOF? Come on, anyone? Anyone? Brownie points. Come on. What is this? Yes, what is this, guys? Come on. I've given you the hint. It's on the screen. No, it is okay. VSD, RVH. Okay, Agon string appearance. Yes, the answer to this question is Agon string or Agon side appearance in transposition of great arteries or TGA. Yes. Okay. Okay. This, come on, guys. What is this? Come on, guys. What is this? What is this? Yes, TAPVR, but can you be more specific? More specific. Can you be more specific? TAPVC or TAPVR? Anirudh, Nirisha, Mukesh, can you be a little more specific? What type of TAPVC? It is a supracardiac. Remember, guys, supracardiac TAPVC. Please remember. Supracardiac TAPVC. Okay? Right. Okay. Look at this, guys. Look at this. There are 2 signs that I've indicated here. 2 signs that I've highlighted here. Yes, yes. What is this? This is a figure of 3. This sign is figure of 3. This sign is figure of 3. Yes. And can you see here? Can you see here on the inferior margin of the rib? Inferior margin of the rib, there is some notching. Inferior margin of the rib, there is some notching. What is this, guys? What is this? Yes, Pooja, you're right. Yes, Dr. Stark, Krishna, Medico Pro. You're absolutely right. Mukesh, Anirudh. You're right, guys. Ahmad, yes, you're right. This is coarctation of aorta. Coarctation of aorta. Come on, guys. Few MCQ points. Come on, few MCQ points for you. Let's see who can answer all of those properly. Come on. Yes. One cardiac anomaly is compulsory. It is not compulsory, my friend, but it is usually asked. And it is very easy to score, very easy to get it right. Okay? So it is very easy, guys. Come on. Tell me, most common side. It is distal. Most common side means distal means after. Distal to left subclavian artery origin. Okay, guys, remember this. Distal to left subclavian artery. These collaterals that you see, guys, the inferior rib notching that you see, it is because of collaterals that are developed. Because the collaterals are passing through. Okay, they erode the inferior margin of the ribs, inferior rib notching. These collaterals come from where? They come from the intercostal arteries, guys. Intercostal arteries. Okay, number 3 to 8 to be more specific. Okay, so from the 3rd to the 8th intercostal space, the arteries there will provide the collaterals. What is Roseler's sign, guys? Roseler's sign. Come on. What is Roseler's sign? Roseler's sign. Roseler's sign is nothing, guys, but the inferior rib notching that you see. Inferior rib notching that you see is known as Roseler's sign. Reverse 3 or E sign. What is this, guys? Come on. Anyone? Come on, this is a brownie point. This is a special point. What is reverse 3 or E sign? And on which investigation do you see this? Okay, so remember, guys, whenever there is 3, okay, it means the coarctation is there and there is bulge. There is a... So this indents or this puts a pressure on your esophagus, which is passing posteriorly. So if this is the 3, the esophagus here, it becomes like this. Okay, so this is E or reverse of 3, because if this is 3, your esophagus becomes like this. That is E sign or reverse 3 sign. This is an indentation on esophagus seen on barium swallow. Remember, esophagus is seen on barium swallow, guys. Basics, guys, basics. Okay, look at this. I've given you the diagnosis, guys. I've given you the diagnosis. Look at this. The earliest sign on chest X-ray, okay? Solving your query once and for all, guys. The earliest sign of mitral stenosis on chest X-ray is fullness below the left pulmonary artery. Do you remember the left heart border, guys? Do you remember the left heart border? We spoke about it at least 2 to 3 times. Come on, fast. Come on, quickly, guys. Left heart border. What is it made up of? Come on, come on, come on. Yes. Top to bottom. Aortic knuckle, left pulmonary artery, left atrial appendage, and the left ventricle. Okay, so this becomes straight, this becomes straight. Okay, look at this, this becomes straight, and this is known as the straightening of the left heart border. If this is the only one in the option, then you mark that as the earliest sign. But if it says fullness below left pulmonary artery, that is the usually that is the first sign. Okay, look at this. Look at this, guys. What is this? Can you see the 2 margins? Can you see? Normally what happens is that usually the right atrium can extend till here. Okay, usually the right atrium can be seen, but here you see 2 shadows. The left atrium is enlarged and it is moved towards the right. Okay, this is known as our double density signs. You can see 2 shadows, guys. This is because of enlargement of which chamber? I already told you the answer, guys. It is in the picture. Which chamber is enlarged in mitral stenosis? Guys, very easy concept. Mitral stenosis means what? Look at this. Look at me. This is the mitral valve. This is the left atrium. This is the left ventricle. And between them is a mitral valve. Mitral valve is narrow. It is narrow. It means the left atrium is trying to push through the narrow valve. Blood is not going. Eventually, the left atrium becomes enlarged because of pooling of blood. Because of it's trying to push, it becomes enlarged. Which chamber is enlarged, guys? Which chamber is enlarged? Answer is left atrium. Okay. Okay, remove those lines. Fine. Look at this. Okay, can you see now? Okay. Look at this, guys. Look at this. What can you see here? Okay, is this a CT scan or an MRI? Come on. Come on. What is this? Is it a CT scan or an MRI? What is this? Come on, guys. What is this? Is it a CT scan or an MRI? Yes, look at the bones. Look at the bones, guys. It's absolutely white. Look at the bones. The bones are absolutely white, guys. This is the scapula. Scapula. These are the ribs. This is the vertebrae. Okay. This is the sternum. The bones are absolutely white. This is a CT scan. Okay. This is a CT scan. Look at the vessels, guys. This is the vessel. The vessel is also white. This is a contrast enhanced CT scan. Okay. What do you see? This is a vessel. Look at this, guys. A vessel is coming here. What is this? This is a very commonly asked question. Okay, it is a new question that has been coming. This is known as our aberrant right subclavian artery. What happens, guys, is that the right subclavian artery usually arises from the brachiocephalic trunk on the right. Okay, brachiocephalic trunk on the right will give rise to your common carotid and right subclavian. But here what happens is the right subclavian comes from the left side. It comes from the left side and passes behind the esophagus and comes to the right. So when it passes behind the esophagus, it compresses the esophagus. When it compresses the esophagus, the person has difficulty eating and swallowing, and that is called dysphagia. The specific term is dysphagia lusoria. Dysphagia lusoria. Okay, okay. How do we identify between MRI and CT? Yes, okay. Again, look at the bones. Look at the bones. Okay, that is the biggest clue. The most important clue is the bones. If your bones are plus 1000 Hounsfield units, if the bones are absolutely white and shining, that is a CT scan. Look at the air, guys. Remember the mnemonic cat? Pitch black, minus 1000 Hounsfield units. Lungs. Okay, so all of these point towards a CT scan, not an MRI. Okay, look at this. Look at this, guys. So I'll tell you, this is an X-ray of congestive cardiac failure. Okay, so what you see here is, look at this, the prominence of the vessels here. Prominence of vessels in the upper part, towards the upper lobe. This is known as the cephalization of vessels. This is known as a cephalization. That is usually the first stage. Then later, look at these peripheral lines. Can you see these small lines developing in the periphery? All of these are because of fluid overload, the excess of fluid that has been collected. Okay, this is known as the curly B lines, and eventually Eventually, the patient will land up in these, look at these perihilar collections known as the classical bat wing pulmonary edema. Bat wing pulmonary edema. This is a classical feature of congestive cardiac failure. Okay, curly B lines, cephalization, and bat wing pulmonary edema. Okay, come on, guys, come on. Very easy, very simple, very commonly asked. What is this? What is this? Come on, quickly. What is this? What is this? Takotsubo? No, this is not Takotsubo. Look at this. Look at this money bag appearance. Money bag appearance. Okay, this is pericardial effusion, guys. This is pericardial effusion. Okay, fluid accumulating around the heart gives cardiomegaly. It gives an appearance of money bag or water bottle. This is pericardial effusion. Don't forget. This is an echo. This is a 2D echo in which you can see the heart. You can see the pericardium, and you can see the fluid between the heart and the pericardium. Pericardial effusion. If pericardial effusion compresses on your heart, on your RV, it causes hemodynamic compromise. That is nothing but cardiac tamponade. Cardiac tamponade. Okay, guys. Do you know what is the triad of cardiac tamponade? What is the triad of cardiac tamponade? Come on, guys, quickly. Yes. Triad of cardiac tamponade. Okay, moving on. If anyone remembers, tell me in the comment section or tell me in the live chat. Okay, look at this, guys. Again, what is this? Is it CT or MRI? Come on. CT or MRI? CT or MRI? Come on. Look at the bone, guys. Look at the bone. Look at the scapulae. Look at the scapula. Look at the sternum. Look at the vertebra. What is this? This is a CT. Very good. This is a CT. Okay. Look at this, guys. What was this vessel? What was this vessel that I told you? What was the vessel that was coming from the front and going behind towards the left? What was this? What was this? This was your ascending aorta. Ascending aorta. What do you see in your ascending aorta, guys? What is this? What do you see? This is nothing but a dissection. There has been a break. There are two lumens in your aorta. This is aortic dissection. Aortic dissection. Remember, if ascending aorta is involved, it is known as Stanford A. If ascending aorta is not involved, it is known as Stanford B. But what if ascending and descending both are involved? What then? Obviously, it is still Stanford A. Stanford A only tells you one thing. It doesn't matter which part of aorta is involved. If ascending is involved, I'm Stanford A. If ascending is not involved, I'm Stanford B. Simple. Okay? Stanford A, Stanford B. Okay? What is the investigation of choice? Come on, guys. What is the investigation of choice here? What is this investigation that you see? It is CT. It is CT, but CT what? CT of an artery, CT of an angio, CT angio. What is the initial investigation that you do? Usually what we do is a transesophageal echo. Initial investigation can be done, but what is the investigation of choice? It is CT angio. Yes. Most important risk factor. Come on, guys. You cannot get this wrong. What is the most important risk factor? Why do you think the artery will just get torn suddenly? Why do you think? What can tear the artery in just a moment? Yes, hypertension. Very good, Jeevan. Very good. Yes, Nirisha. Yes. Have a tearing, radiating pain. Yes, radiating towards the back. You're right. It is a tearing type of pain, usually seen in hypertensives. So the most important risk factor is hypertension. Okay. What is the management of Stanford A? Come on. If ascending aorta is torn, if ascending aorta is involved, there's nothing else that you can do. You have to take the patient up for surgery. But if ascending aorta is not involved, you can do a conservative management. You can reduce the BP by giving something like esmolol. Esmolol is a beta blocker. Okay. So you can give something like esmolol. But if ascending aorta is involved, there is nothing else you can do. You have to take the patient up for immediate surgery. Yes. Everyone is right. Okay. Moving on. Come on. Look at this, guys. Look at this. Aortic aneurysm. I've given you a diagnosis. What do I want to know? I want to know what is the most common site of aortic aneurysm. Come on. Anyone. What is the most common site for aortic aneurysm? Yes, Anirudh, absolutely right. For B, control BP. That is absolutely correct. Drug of choice, esmolol. Yes. Come on. What is the most common site of aortic aneurysm? Abdominal aorta. Can you be more specific? It is the infrarenal abdominal aorta, guys. See, this is the abdominal aorta. It gives the branches. That is the renal artery. Okay, then continues and divides into your iliacs. So the abdominal aorta, the most common site is below the renal branches. infrarenal abdominal aorta. This is the most common site of aortic aneurysm. Okay, infrarenal abdominal aorta. Okay, great. Now, sometimes what happens is that there is pseudoaneurysm. Aneurysm means bulging of all the layers. So, if this is the wall, okay, if this is the wall of the aorta, then what happens is that everything will bulge. All the layers here, they will bulge. This is the aneurysm. But what happens in pseudoaneurysm is that sometimes some of the layers will continue, but some of the layers will bulge. Not all layers bulge. This is known as your pseudoaneurysm. So, why is this important? Why is it important? Because if I keep a USG probe here, if I keep a Doppler probe here, and if I see, sometimes what happens is the blood comes towards me. I get one color signal, say red, but then the blood goes away from me. I get another color signal, say blue. So blood is coming, going, like a circle, and this is what I get. This is what I get. This is known as the yin and yang sign. This is known as the yin and yang sign on Doppler in pseudoaneurysm. Simple, guys. Is it simple? Is it logical? Is it conceptual? Okay. Come on, guys. Come on, just tell me. Are you understanding? Are you enjoying this class? Okay, this is absolutely important and very simple, guys, but very important. Come on, guys, come on. Investigation of choice is again angio. It has to be a CT angio, right? Okay, guys, I've given you the clue. This is pulmonary embolism. What is the sign? What is the sign? There is an arrow here. What is the sign? Come on, guys. What is the sign? Very simple. Come on. Come on, try. You can be wrong. You can be wrong. It's absolutely okay to be wrong. Come on. I have been wrong on many occasions in front of everyone. It's okay. Please tell me. Please speak up. Yes, Jivan, absolutely correct. You're absolutely correct. You can see a hump here. You can see a wedge-shaped opacity, usually representing a lung infarct. This represents an area of infarct, guys. And this is known as the Hampton's hump. This is known as the Hampton's hump. Okay. What is this, guys? Come on. What is this? I've circled it for you. What is this? This is another sign of pulmonary thromboembolism. What is this sign? Can you see? Can you see what is happening? You can see a lot of blood vessels here, but here you can see that there are very few blood vessels. Okay, in this particular area, in this particular focus, this is known as focal oligemia. Olig means less, emia means blood flow. In this focus, in this area, there is decreased blood flow. What is this sign? Yes, Tranquil Nirisha, you're absolutely right. This is the Westermarck sign. Okay, Westermarck sign. And this again. Come on, guys, for the nth time. What is this? Is this a CT scan or is this an MRI? Is this a CT scan or is this an MRI? Come on. What is this? What is this? Come on. Yes, Spartan, you're absolutely right. You have to shout at the top of your voice that this is a CT scan. This is a CT scan. What do you see, guys? What do you see? Can you see? Can you identify this vessel, guys, for me? What is this vessel? I've already told you in our radiological anatomy part. What is this vessel, guys? What is this vessel? Come on, quickly, guys. We have a lot to cover. What is this vessel? This vessel is known as your pulmonary artery. Okay, this is the main pulmonary trunk. Pulmonary artery. There is white pulmonary artery. It means there is contrast in there. It's a contrast enhanced CT scan. Wonderful. What do I see? I see this area of black part. This black area, can you see? This is a filling defect. This is a filling defect, and this is a saddle thrombus. This is a thrombus. Thrombus in pulmonary artery. Pulmonary thromboembolism, guys. Pulmonary thromboembolism. And what is this investigation? This is the CTPA. That is CT, pulmonary angiography. Pulmonary artery we are looking at. You can see a proper saddle thrombus there. This is CTPA, CT pulmonary angio, and this is the investigation of choice to diagnose pulmonary thromboembolism. Okay, let's go, guys. Neuro. We're done with thoracic radiology, guys. Come on, tell me, did you enjoy? Come on, quickly. Did you enjoy thoracic radiology, guys? How did you find it? For DVT, you do a duplex scan. Okay, a duplex scan, investigation of choice, like I said. Okay, the first investigation usually is a duplex scan. But if you tell me what is the more sensitive one, it has to be your CT angio. Okay, but that is for artery. If you say for DVT, yes, the duplex scan is your investigation of choice. Come on, guys. break. No, not yet. Come on. We have a lot to cover, guys. We have a lot to cover in a short period of time. You need to know everything, guys. You need to know everything. You need to top the exam. Come on. I'm considering as if I'm sitting for this exam, guys. Okay. I am about to give this exam. That is my mentality. This is what I will prepare. This is how I will prepare. Okay. Come on. Yes, color Doppler duplex. Okay, see what happens in DVT. I'll tell you one point. Normally on duplex or Doppler, the vein is compressible. There is a monophasic flow. The vein is compressible. In DVT, this deep vein thrombosis means if this is the vein, if I'm compressing with my probe, normally I will compress it. I'll be able to compress it. But if there is a thrombus inside, if it is a block inside, if I press with my probe, do you think I'll be able to compress it? No. So the compressibility is lost, and that is a feature of DVT, deep vein thrombosis. Okay, an extra point for you. Right, come on. Neuroradiology, guys. Come on, let's go. CT scan. Like I said, can you identify the CT scan? Okay, the bone, the cortical bone is absolutely white. Okay, CT scan. Come on, guys. You need a break. Do you guys need a 5-minute break? Come on. Just tell me before we go into neuroradiology. Do you guys need a 5 minutes break? Because it's barely been what, say, just 2 hours, 2.5 hours. No break. Okay. That's wonderful. Let's go. Okay, so let's go. This is CT scan. Okay, CT scan, a cortical bone. Can you see absolutely white? Plus 1000 Hounsfield units. CT scan. Look at this MRI. Do you think that is cortical bone? Do you think, compare this, guys, compare this whiteness and this whiteness. Do you think it's the same? It is not the same, guys. This is scalp fat. Okay, this is scalp fat. This is scalp fat, guys. This is not the bone. Please embed this image in your minds. This is CT scan. This is how the cortical bone will look. Okay. What is this black? What is this black inside? It is air. Cat first. Remember what air? It is the sinus, guys. It is the frontal sinus. Wonderful. Okay, let's go. This is a CT scan. This is the MRI. Appearance of bone, like I said, white, or it can be variable. Gray white matter cannot be distinguished. Look at this, guys. Look at the MRI. Can you see this gray matter? Can you see the inside white matter? Can you see absolute clarity, distinction between the two? Yes, this is possible on an MRI and not usually on a CT scan. Okay, so gray white matter differentiation, and like I said, MRI has to be investigational choice in stroke, in CNS tumors, infection, demyelination disorders, everywhere investigational choice has to be MRI. Let's go. Normal. This is the normal MRI, normal anatomy, guys. Okay, this is the right side. This is the left side. Okay, this much is clear. Okay, this is the midline. Okay, so this has to be a temporal lobe. Look at this, temporal lobe. Okay, this is your frontal lobe, and posteriorly what you have is a occipital lobes. Okay, this is what view, guys. Come on, what view? I told you it's the transverse or the axial view. What view is this, guys? What view is this? Come on, tell me, what view is this? This is the mid sagittal or the sagittal view. Okay, from the sagittal suture we've taken and looking at it from the side. Okay, look at this giant structure. What is this? This is the corpus callosum, midbrain, pons, medulla. This is the brain stem. Can you see the brain stem, the cerebellum, the fourth ventricle in between? Okay, so all of these are very basic structures that you need to know, that you need to identify, and the medulla continues downwards as the spinal cord. Okay, which is right, which is left? Remember, guys, whenever you look at a CT film or an MRI film, whatever, always imagine you looking at the patient from his legs upwards. It means if the patient is lying down, look at this pencil. Can you see this patient is lying down? This is the leg of the patient and this is the head of the patient. You looking at the patient from here, from the leg end. Now imagine if you're looking someone from the leg end, towards your left will be the patient's right, and towards your right will be the patient's left. And this is how you remember. If you see this, looking at the patient from his leg end, this has to be the right and this has to be the left. Okay, come on. Okay, guys, look at this CT scan. Like I said, again, cortical bone. Look at the cortical bone. Okay, look at the cortical bone. This is a CT scan. The CT angio. Can you see the cortical bone? It is CT. Can you see the blood vessels, guys? Can you see the blood vessels here? Can you see the arteries here? Can you see the carotids? This is an angio. This is an angio. CT angio. Look at this, guys. What do you think this is? Come on. What can you see? This is also CT scan. Look at the cortical bone. This is a CT scan. What can you see? Come on. What is this? All this black structure. What is this? What is this? What is this? Yes, this is your temporal bone, guys. Temporal bone. This is temporal bone. Can you see all those air cells, the mastoid air cells, and all of those things? Can you see the black part? Yes. So for temporal bone, for middle ear, for inner ear, you do an HRCT. This is, guys, this is an HRCT temporal bone. This is an HRCT, a high resolution CT of temporal bone. Look at this, guys. Look at this. So many colors. A colorful image. Is this CT? Yes. This is CT. I can look at the cortical bone and tell CT. What is this? Do you think this is contrast? No, contrast appears white. What is this? So many colors. This is a perfusion scan, guys. This is known as perfusion scan. CTP, perfusion. This is for assessing cerebral blood flow. Cerebral blood flow. Okay. Right. So all of these are just images that you need to know. Okay, MRI. Look at this, guys. Look at this. This is not cortical bone. Please, again, I'm showing you the cortical bone. Look at this. Look at the thickness of this and whiteness of this cortical bone. And now compare it with this. Do you think it's the same? It's not. This is the scalp fat. This is an MRI. This is an MRI. This is a T1 weighted MRI. Different sequences. Okay, remember. How do you know? In first year, you study anatomy, don't you? In first year, you study normal anatomy. So T1 weighted will show you normal anatomy. In normal anatomy of the brain, the gray matter is outside, the white matter is inside. So outside you see gray matter. Can you see the dark region outside? And inside you see white matter. And the fluid is black. This is T1 weighted. T1 weighted, first year anatomy, remember, over. T2 weighted, it is the opposite. T2 weighted, in second year you study pathology, abnormal, opposite of normal. So second year pathology, opposite of normal means the normal structures, the normal anatomy will be oppositely represented. So the gray matter will appear white and the white matter will appear darker or gray. This is the reverse, Uno reverse. Okay. And what happens to the CSF? Remember World War II, water appears white on T2 MRI. Water appears white. CSF is nothing but water. So water appears white on MRI. Remember, guys, white lesions on MRI, white areas on MRI are known as hyper intense. On CT, they were hyper dense. On MRI, I has intense. MRI is intense. Okay. This is your T2. Look at this flare. Come on, guys, tell me, what is flare? Flare stands for fluid attenuation inversion recovery. Fluid attenuation inversion recovery. It is nothing but it is T2. What was the feature of T2? That gray will appear white. White matter will appear gray. And fluid or CSF will appear white. World War II. What I do here is I break this. Fluid attenuation. I attenuate or weaken the fluid signal. The fluid now will appear black. Okay. So fluid appears black. Can you see? Look at this. Look at this, guys. Okay. Can you see the outer aspect is white? The inner aspect is gray. That is opposite of normal anatomy. Has to be T2. Array, but water is not white. This is a T2 sequence, but water is black here. This has to be a flare sequence. Flare sequence, guys. Okay. Yes. Flare sequence. Flare is just a sequence of MRI, guys. There are various sequences or types of MRI, if you will. T1 weighted, T2 weighted, flare, stir, ADC, DWI. All of these are various types or sequences of MRI. The basics remain the same. Look at this, guys. Look at this. This is a diffusion weighted MRI. DWI, diffusion weighted MRI. This area is hyper intense again. Okay, known as diffusion restriction. Okay, these are the various causes. Various causes. What happens is that diffusion restriction means hyper intense on DWI, or on ADC it is hypo intense. Same regions. Look at this. Look at this. If you don't understand, look at this. Can you appreciate this area here on DWI? Is it white? Is it white? Come on, yes or no? Is it white? Come on, guys. Is this area white? Okay, confused about which part? Come on, tell me. I'll explain it to you. This area is white. This is hyper intense. This area is black. This is hypo intense. Same area appearing white on DWI, appearing black on ADC. This is known as diffusion restriction, guys. This is one step higher, one step above, and this is usually seen in a hyperacute infarct, brain infarct, most sensitive. Okay. Yes, yes. Hyperacute infarct, guys. Okay. Right. If you want to know the other causes of diffusion restriction, you can. But since time constraint is there for me and for you, I'll just tell you, just remember acute infarct and abscesses. Okay, these two should be enough for diffusion restriction. Moving on. SWI, guys, SWI, susceptibility weighted imaging. Remember, susceptibility weighted imaging, investigation of choice for DAI. What is DAI? Guys, listen to me very carefully. Very commonly asked, very easy, very scoring. DAI stands for diffuse axonal injury. Diffuse axonal injury. Guys, DWI stands for diffusion weighted imaging. Okay, diffusion weighted imaging. Okay, right. DAI stands for diffuse axonal injury. What happens here is that a person, the question asked will be that a person has come to you after a traumatic accident, a road traffic accident, or some trauma to the head. The person's GCS is very poor. GCS is poor, not improving. You've done CT scan of the brain. There is no bleed. CT appears to be normal, grossly normal. If CT appears normal, still the patient's GCS mental state is very poor. How do you explain that? It can be DAI, and this is how the question is asked. Diffuse axonal injury. The question asked is number one, which sequence of MRI is the most sensitive? The answer has to be your SWI, susceptibility weighted imaging. Okay, what happens in diffuse axonal injury is that there's shearing, there's stretching and tearing at the gray white matter junction. Most common site, gray white matter junction, there is tearing. Okay, and there is micro bleeds. All of this black that you can see, guys, all of these black lesions that you can see, these are bleeds. Okay, so diffuse, yes, axonal injury can be seen on which sequence? SWI. Okay, yes, diffuse axonal injury can be seen on, yes. Okay, guys. Okay, so DAI, yes, this stands for something known as diffuse axonal injury. Okay. Okay. Yes, come on. This is a GRE sequence. Okay, GRE stands for something known as gradient echo, guys. It stands for gradient echo. Now, this is also a sensitive sequence to pick up bleeding and calcification. Can you see similar black dots? These are also bleeds, micro bleeds that you can pick up on GRE. Okay, one last part, MR spectroscopy. Okay, you can see these peaks. There are various peaks, various substances having peaks. Okay, this is spectroscopy. This is a N-acetyl Na peak. Okay, NAA peak. This is normal. Remember N for N. Okay, N for N is NAA peak is a normal peak. Lipid lactate peak is seen in TB. How do you remember, guys? TB, Mycobacterium tuberculosis, the cell wall is made of mycolic acid. Mycolic acid is a lipid. So lipid peak or lipid lactate peak is usually seen in tuberculosis infections of CNS. And choline and creatinine peak. Remember, as choline and creatinine are used for cell turnover. Whenever cells replicate or multiply or divide, it is usually seen in tumors or cancers. And this is where you get a choline creatinine peak. Okay, if you remember, it's fine. If you don't remember, just know that lipid lactate peak is seen in tuberculosis. Okay, guys. Okay, are you still there? Are you with me, guys? How is it going? Are you enjoying? Are you understanding? Is there any confusion? Please let me know. This session is for you. Okay, you are the most important people here. You tell me. Are you enjoying? Is this fine? Is the speed fine? Everything is good? Okay. All right, wonderful. Let's move ahead. Okay, so head trauma. Remember NCCT brain, I gave you a mnemonic CCT. Okay, CCT, the T was for trauma. So when any patient comes to you with traumatic brain injury, remember TBI stands for, yes, traumatic brain injury. Okay, so patient has come to you with traumatic brain injury. What do you do? The next step is to assess the GCS, the Glasgow Coma Scale. Okay, the GCS has to be assessed first. Okay, in GCS, you calculate eye opening, verbal, and the movements, the voluntary movements. Okay, so if the GCS is more than 12, then what you have to do? If GCS is less than equal to 12, then what do you do? If the GCS is less than 12, then you guys directly go for an urgent NCCT, investigation of choice. If it is more than 12, then look for any danger signs. If there are any danger signs, what are the danger signs, guys? if the age is more than 60, if there is any focal neurological deficit, if there is headache, vomiting, seizures, all of these things are danger signs. If danger signs are present, then again you go for a CT. Okay, CT scan. Now imagine you are a medical officer, you are a junior resident. Okay, you've cracked your FMG, you've cracked your NEET PG. Now you've taken up medicine or surgery. You're sitting in the casualty. A patient has come to you with head trauma, a road traffic accident. He's being rushed with his relatives in road trauma, head injury. What do? You assess GCS. Look at the pupils. His GCS is less than 12. You get an NCCT done. You get an NCCT done, and guys, what will you see? What will you look for? This is something that you can encounter. Guys, this is something you can encounter. Okay. This is something that you can encounter. Okay, Dr. Parv is here. Thank you. Thank you. That's motivating. That's great coming from you. Right, guys. So this is something you can encounter. EDH, SDH, SH. EDH is extradural, epidural hematoma. SDH is subdural hematoma. SAH is subarachnoid hemorrhage. Subarachnoid hemorrhage. Okay. Remember, guys, this table will help you solve a lot of MCQs, guys. At least 10 to 12 MCQs have come in the past few years from this table alone, guys. Remember, the photos, the words that I've written, this table is more than enough for you to crack questions on this topic. Please pay attention. Please pay attention. Let's see EDH first. EDH is extradural hematoma, means above the dura mater. Can you see the shape? Yes. Yes. Can you see the shape? Yes. Okay. This is a biconvex shape. A biconvex shape of hematoma. Okay, guys. Again, I don't have to tell you guys it's a CT. Look at the cortical bone. Look at the cortical bone. This is a CT scan. Okay. Yes, this is an extradural hematoma. Extradural hematoma. What is the mechanism? It's a high energy trauma. High energy trauma. A patient has come to you with road traffic accident. You see the GCS less than 12. You get an NCCT. You see this picture. This is an extradural hematoma. What is the most common site from where this bleeding has occurred? It is the middle meningeal artery. Middle meningeal artery. Guys, remember one important connection to anatomy. In anatomy, they show you a photo of the lateral aspect of the skull. They mark a point. The point is pterion. They ask you, what is the artery that lies beneath the pterion? This artery is the most common site for extradural hematoma. The answer has to be middle meningeal artery. In 1 year, they ask which branch of middle meningeal artery. The answer has to be anterior branch of middle meningeal artery. Okay, guys? Come on. Yes, wonderful. Okay, pterion, MMA. Okay. So we discussed so many MCQs, guys. Okay, I hope you're paying attention. Okay, right. So there's special point is a lucid interval, means the patient is drowsy or altered in say for 5-10 minutes, and the patient is back, he's conscious, he's talking for a few minutes, and then again he goes back into the drowsy state or the altered state. This is known as a lucid interval. This is known as the lucid interval, a very characteristic feature of extradural hematoma. Can it cross the suture lines? No, it cannot. Why? Because the dura mater is attached to the suture lines. If it is taking place, the bleeding is above the dura, do you think it can break the dura and cross the suture lines? No, it cannot. But can it cross the midlines? The answer is yes. Okay, right. Subdural hematoma. Look at this, guys. Look at this. Can you see this bleeding here? Can you see this bleeding here? This is a subdural hematoma, guys. Subdural hematoma. Okay. Yes. How to remember concave versus convex in this image? Look at this. Look at this. Look at this. What is the shape here? What is the shape here? Okay, I'll erase it so you can see better. Okay. Yes. Look at this. What is the shape here? Okay, it is convex. Look at this. This is one convex surface. This is another convex surface. This is a biconvex shape of extradural hematoma. Okay, look at this. This is a crescent shape. This and this. Crescent shape. This is our subdural hematoma. Now remember, guys, how does the question come? I told you extradural hematoma. You will see a young male or a young patient comes to you with road traffic accident, poor GCS. You get an NCCT done. You find this. They'll give you a history of lucid interval also. What is the diagnosis? Extradural hematoma. Subdural hematoma. Elderly, usually chronic alcoholics. Okay, trivial trauma, very trivial, very small, mamuli, very trivial trauma history. They come to you, altered sensorium. You do a CT scan, NCCT brain. You see this finding. What is that? That is subdural hematoma. What is the site? It is a cortical bridging veins, guys. Cortical bridging veins. Special point, it is also seen in battered baby syndrome. Come on, guys, FMT correlation. Okay, it's also seen in battered baby syndrome. Okay, does it cross the suture line? It is exactly opposite of external hematoma. If external hematoma cannot cross the suture line, this guy can. If external hematoma can cross the midline, this guy will not. Exactly opposite. That's how you remember. And the last one, the most dangerous one of them all is the subarachnoid hemorrhage. And can you see this, guys? Can you see this star that is being formed here? Okay, this is the star of death. This is a star of death, and this is subarachnoid hemorrhage. This is bleeding into all your fissures. The most common cause of subarachnoid hemorrhage is trauma more than aneurysm. Remember, rupturing of aneurysm is not the most common cause. It is traumatic again. If the aneurysm ruptures, the question is, if the aneurysm ruptures, what is the most common site of that aneurysm? It is your anterior cerebral artery, your anterior communicating artery branch. Okay, this junction is where it'll occur. Okay, guys, just give me a minute. Just let me attach my charger. Okay. Yes. Star of death. Yes, you're absolutely right. Star of death. Okay, right. Thunderclap headache, worst headache of my life. This is what you have to keep in mind. This is a keyword that you're looking for in a question stem. Thunderclap headache, worst headache of my life. Your answer has to be subarachnoid hemorrhage, nothing else. Okay, very simple, guys, very simple. This is what you will see. Please go through this table. You will encounter a question or two and you will mark it right, I'm confident. Okay, let's go. Okay, now one extra point, one brownie point, one step above. Okay, in external hematoma, can you see this is biconvex? Yes, this is an external hematoma. If you see within the hematoma, you can see some white areas and you can see this black area. This black area is usually a sign of active bleed, means the vessel is still bleeding, the middle meningeal artery is still leaking. Okay, it is an active bleed, and this is usually known as the whirlpool sign or the swirl sign. Let's move on. Okay, come on, guys. Yes, again, what is this? Come on. Mount Fuji sign. Come on, I've given you Mount Fuji sign. What is this? It is found where? Mount Fuji sign is seen in. Come on, guys. Come on, tell me. Mount Fuji sign is seen in. Yes, Suji, you're right. Tension pneumocephalus. Pneumo means air. Cephalus means in your brain, in your cranium. Pneumocephalus, again, air, best friend of CT scan. You will see tension pneumocephalus in Mount Fuji sign. Look at this, guys. Look at this. What did I tell you? What is this? This is a CT scan. You can see the cortical. Bone. See the CSF. Is it black? Here it is black. And there's something here that you can see. This is not CSF. It's not black. This is not bone. It is not as white. It is something between the CSF and the bone. And I told you one thing that you need to remember. What was that? Yes, that was your hemorrhage. Yes, hemorrhage. Yes, hemorrhage. IC bleed, intraparenchymal bleed. Absolutely right, guys. There is something special about this hemorrhage. There's something very special about this hemorrhage, and it is the site of this hemorrhage, guys. It is the site. Do you know what passes here? This is the internal capsule. This is normally the site of internal capsule. I'll remove all the other markings so that you can see it clearly, guys. Okay. Normally what we have here is the internal capsule, guys. This is the internal capsule, and normally what we have here is the lentiform nucleus, guys. This is the lentiform nucleus, which bleed. Yes, gangliocapsular region. Absolutely right. GC region, gangliocapsular region, which bleed presents here. It is the hypertensive bleed. Okay, the most common risk factor is hypertension. The most common sign is putamen, known as the GC region bleed, gangliocapsular region bleed. This is a hypertensive bleed, guys. Okay, stroke imaging. Guys, let's again just breeze through the stroke imaging. Okay, something very important. We'll just look at it very briefly. No fancy details, nothing more than what we need. Okay, hyperacute stroke less than 6 hours. Investigation of choice. I told you, investigation of choice is MRI. Which sequence of MRI? Yes, come on. Which sequence of MRI, guys? Which sequence of MRI? The answer is right here. DWI with ADC map. Okay, look at this. You can see hyperintensity here, white, and a similar region you will see hypointensity on ADC, dark. Okay, W means white, D means dark. So on DWI you will see white. Same region on ADC you will see dark. This is most sensitive for hyperacute infarcts. On CT, what will you see? There are certain name signs. Look at this. This is the middle cerebral artery, hyperdense MCA sign. And sometimes you will see the disappearing basal ganglia sign. Like I said, normally you can see the internal capsule and you can see the lentiform nucleus. This is a part of basal ganglia. But here, can you make out? Can you see anything? No, you cannot see anything. The basal ganglia has just disappeared. This is known as the disappearing basal ganglia sign. Okay. Yes. A very common question that was asked before, but I don't think it has been asked anymore. Can you see this? The puff of smoke appearance? Yes. Puff of smoke. Can you see this? Puff of smoke. Yes, thrombolysis is a treatment. Yes, thrombolysis is treatment in non-hemorrhagic infarct. Also, only if you present within the window period. Within the window period of 4.5 hours, if the patient has come to you, you see that the non-hemorrhagic infarct is there, only then you will think of thrombolysis. What agent do you use? Come on, Nirisha. Jeevan, tell me what agent will you use for thrombolysis, commonly used? Okay, it is your tenecteplase. Okay, alteplase, etiplase, tenecteplase, those group of agents. Tenecteplase is commonly used. Okay, yes, tenecteplase. Yes, absolutely wonderful. Tenecteplase. Okay, right, guys. Tumors, again, CNS tumors, like I said, investigative choice has to be MRI without a second thought. Infection, seizures, tumors, demyelination, everything from brain, stroke, everything, answer has to be MRI. Okay, look at this, guys. Look at this. Can you see? This is a tumor. It has a tail. Okay, there is. Okay, it is attached to the dura with a tail. This is known as the dural tail sign. Dural tail sign, very specific for one tumor. Most common benign tumor of the brain. Come on, guys. Which one is it? Which one is it? Tell me. Which one is it? Dural tail sign. Most common benign tumor of the brain. Come on, guys. Fast, guys. Come on. Which one is this? Which tumor is this? Come on. You know it. Yes, Abdullah. Absolutely amazing. This is meningioma. Okay, especially young females, dural tail sign. On angio, there is something known as mother-in-law phenomena. It means that whenever you do angiography, whenever you inject the dye enters the tumor very fast, very early, but leaves very late. Okay, so someone said it is like the mother-in-law who comes quickly, very early, but just doesn't leaves very late. Okay, so that is just one part that you need to remember. Associated with neurofibromatosis 2, NF2. Remember that. NF2, I'll give you a mnemonic. The mnemonic is MISME. MISME. Multiple inherited schwannoma, meningioma, ependymoma. Multiple inherited schwannoma, meningioma, ependymoma. This is the mnemonic for NF2, neurofibromatosis 2. Come on, guys. What is this? Come on. Guys, I'll give you a hint. A very aggressive tumor. WHO grade 4 tumor. Very aggressive. Crosses the midline. Can be butterfly shaped. Crosses the midline. Can be butterfly shaped. WHO grade 4. Yes. Okay, NF2 stands for neurofibromatosis type 2. Okay, this is NF2. This is glioblastoma, previously known as glioblastoma multiforme. Most common malignant brain tumor, WHO grade 4, can cross the midline, and that is what you need to know. Okay, so mnemonic, I'll write the mnemonic here. This is the mnemonic, guys, for NF2. The mnemonic is multiple inherited meningioma, schwannoma is there, and ependymoma. Multiple inherited schwannoma, meningioma, ependymoma is MISME. Okay, let's go. Okay, look at this schwannoma. We were talking about schwannoma. Okay, this is the most common CP angle tumor. Remember, guys, CP stands for cerebellopontine angle. Okay, we all know the brainstem. Brainstem, what do we have? Yes, we have the midbrain, we have the pons, okay, and then we have the medulla, and we continue the spinal cord. Here is your cerebellum. So this is the angle. This is the site, cerebellopontine junction or cerebellopontine angle. The tumor here, the most common tumor here is vestibular schwannoma, also known as acoustic schwannoma. Okay, this is the most common CP angle tumor. You can see here, it looks like an ice cream cone. Okay, this is the cone, and this is your ice cream. Okay, why does it look like this? Because it arises from your eighth nerve. Okay, the vestibulocochlear nerve, and the eighth nerve is now entering into the internal acoustic meatus. Okay, it is going in. Okay, so the tumor follows. Okay, correct? Yes. Look at this, guys. Okay, this is another important thing that you need to know. A very few questions have been asked, but they have been asked. Pilocytic astrocytoma, most common benign tumor in children. Most common site is cerebellum. Okay, come on, moving ahead. Medulloblastoma arises from the roof of fourth ventricle. If there is a tumor arising from the floor of fourth ventricle, it is known as ependymoma. Again, ependymoma, part of NF2, neurofibromatosis 2. Okay, medulloblastoma is notorious to cause drop metastasis. Drop means it will drop, the tumor will drop into the spinal cord, along the spinal cord, and there will be multiple drop metastases that you can see. So what you do is you give a prophylactic craniospinal irradiation. Okay, you give a radiotherapy prophylactically because you know that medulloblastoma will drop some tumors into the spinal cord. Right? Okay. Pituitary macroadenoma. Macro means more than 1 centimeter or 10 millimeter. You can see, okay, figure of 8. Can you see this figure of 8 of snowman? Where else did we see? Come on, guys. Where else did we see figure of 8 of snowman? Come on, come on, come on. Where else did we see figure of 8 of snowman? Come on, guys, fast. Where else did we see figure of 8 of snowman appearance? In thoracic radiology. In thoracic radiology, yes, TAPVC, but I told you to remember a very specific type of TAPVC, guys. It was the supracardiac TAPVC. Come on, let's go. Okay, this is one additional information that I thought you should know. Bracket calcification, look at this in the form of brackets. This is for corpus callosum lipoma. Moving on. Again, infections, guys. Infections, investigation of choice is an MRI. Okay, investigation of choice is an MRI. Okay. Ring enhancement can be seen. Look at this. Look at this, guys. Can you see the ring is enhancing? Can you see this ring enhancing lesion? Okay, ring enhancing lesion. Ring enhancement is positive, and this usually represents an abscess. It is not specific for an abscess, guys, but it usually is an abscess. Okay. Clinical vignette can be that a patient had ear discharge, continuous ear discharge for chronic for a long time, and then suddenly he develops, high grade fever and develops altered mentation. You do an MRI and you find this. Okay, so there is usually an abscess, a brain abscess, which has gone from the middle ear. Okay, it is eroded, CSOM. Okay, CSOM, unsafe type of CSOM. It can erode the bone, and the infection can land up in the temporal lobe most commonly, because the temporal lobe is the closest to the middle ear. Okay. Tuberculoma, guys. How do you differentiate tuberculoma? You can see conglomerate lesions. Okay, look at this guy. Fusing and conglomeration is present. Okay, this is tuberculoma, guys. Tuberculoma, and I told you on MR spectroscopy a lipid lactate peak. Why? Because Mycobacterium tuberculosis has lipid in its cell wall, mycolic acid to be specific. So lipid lactate peak will be increased or raised if there is something which is more lipid rich. What is that? It is nothing but the organism MTB. Okay, guys. Guys, are you enjoying? Is it fine? Is it too much? Please let me know. Okay, this has to go according to you. This is for you. You let me know, guys. Come on, tell me. Is it fine? I'm waiting for your reply, guys. Come on, tell me. Is it fine? Good? Yes, yes. Others, come on, tell me. Okay, yes, yes. A little long, because I told you the key is not to know everything, but to know a little bit of everything. We're trying just to know 1-2 points about everything. Just 1-2 points, guys. Nothing more. Okay, nothing more. Just 1-2 points. Nothing else, guys. Okay. Yes. Look at this. Look at this, guys. Starry sky pattern. Starry sky pattern of NCC. Neurocysticercosis, guys. Neurocysticercosis, NCC. Seen in Tinea solium, not saginata. Tinea solium, remember, not saginata. Okay. Look at this starry sky appearance. Guys, a pathological question. Starry sky appearance is seen in kidney, in one lesion of kidney. Okay. Do you remember what was it? What was it? Which investigation and which disease of kidney shows starry sky appearance? Can you tell me? In the brain, it is NCC, neurocysticercosis. Don't forget. Come on. Okay, toxoplasmosis. Yes, PSG. Yes, wonderful. Okay, which was the investigation? Which investigation shows starry sky appearance? Okay, toxoplasmosis, guys. Toxoplasmosis. What do you do? Again, the question will tell you about an HIV or an immunocompromised patient. CD4 count less than 200. Okay, if they show you such a lesion in an HIV positive patient, close your eyes and mark toxoplasmosis is the answer. Close your eyes and mark toxoplasmosis is the answer. That is all you need to know. Yes, immunofluorescence is the correct answer. Look at this, guys. Look at this. Can you see these lesions? Can you see these lesions around the ventricle? Around the ventricle. These are known as Dawson's fingers, guys. Dawson's fingers represent zone of demyelination in multiple sclerosis. In multiple sclerosis. Okay, guys. I told you when we were studying MRI sequences for periventricular pathology, which sequence is used? Which sequence helps you identify the periventricular pathologies? Come on, anyone? Anyone? Which sequence helps you identify the periventricular pathology? Come on, fast, fast, guys, fast. Come on, fast. It is a flare sequence, guys. Flare sequence. Okay, flare. Fluid attenuation, inversion recovery sequence. Look at this Dandy Walker malformation, guys. Dandy Walker can be a question. Cystic dilation of the fourth ventricle. Can you see a cystic dilation of the fourth ventricle? Dandy Walker. Molar tooth is seen in Joubert syndrome. Can you see this molar tooth appearance? Molar tooth is seen in Joubert syndrome. All these are one-liners, guys. They have been asked. Eye of the tiger sign. Can you see this eye of the tiger sign? Eye of the tiger sign seen in pantothenate kinase deficiency associated neurodegeneration. Okay, known as PKAN. Pantothenate kinase associated neurodegeneration, and the disease name is Haloverden-Spatz phenomena. Haloverden-Spatz disease. Haloverden-Spatz disease shows eye of the tiger sign. This is known as the eye of the tiger sign. Hummingbird sign, guys. Look at this. Can you correlate this bird? Can you see hummingbird sign? This is known as, this is seen in PSP, progressive supranuclear palsy, guys. Progressive supranuclear palsy. Okay, palsy. This is a type of Parkinson plus syndrome. Okay, progressive supranuclear palsy, hummingbird sign, and this is known as a hot cross bun sign. Can you see this hot cross bun sign? Can you see the hot cross bun sign, guys? Okay, this is seen in MSAC type. MSA stands for multi-system atrophy. Stands for multi-system atrophy. Okay, all these questions have been asked, guys. Okay, all these questions have been asked, and all these are important. Just one-liners, just one points, and we're moving on. Okay, guys, paranasal sinuses. Just quickly, let's breeze through them. Okay, investigation of choice is an HRCT. It is an HRCT. Remember, investigation of choice is an HRCT for paranasal sinuses. These X-rays are asked the views. This is a Caldwell's view. Caldwell's view. What is Caldwell's view? You take your face and you keep it like this on your palm. Do it, guys. Everyone do it. Come on, everyone do it. So what happens is your frontal sinus and your nose, they touch. Okay, so the radiation is coming from behind. This is known as the Caldwell's view. This is to look at the frontal sinuses. Look at this, guys. Look at the beautiful frontal sinuses. Okay, what do sinuses contain? Sinuses contain air. Which investigation is the best for air? Come on, tell me. Which investigation is the best for air? Cat fuss. Cat creates a fuss. Come on, guys. Which investigation is best for air? The answer is on your screen. CT scan. Therefore, the investigation of choice is HRCT. Can you see, guys? Can you correlate the basics? Okay, these are the basics. Let's go. Yes. Look at this, guys. This is the Waters view. Okay, this is how a Waters view is done, and Waters view is for maxillary sinus and orbital flow. Look at this, guys. Look at this. These are the maxillary sinuses. Okay, this is your Waters view. This is Waters view. Just one-liners, guys. They have been asked. This the view is asked. They've asked you what the view is, and they've asked what is it used for. Okay, one last we'll see. This is the Townes view. Townes view is used for deeper structure. It is used for deeper structures like occipital bone and foramen magnum. If you want to see them on an X-ray, then what view will you do? You'll do a Townes view. Okay, let's go. Okay, guys, that's the end of neuroradiology. Neuroradiology, was it too much? Come on, tell me. Was it too much or was it fine? Come on, guys, tell me. Give me your feedback so that I can adjust accordingly. Come on. Are you enjoying? Are you seeing the basics? Are you enjoying? Are you connecting? Is it fine? Yes, come on, tell me, guys. Is it fine? Fine. Okay, okay. Okay, so ready to move on into GIT and hepatopancreaticobiliary. Yes, are you ready? Enjoying? Okay, that's good. Come on, guys. Okay, okay, okay. Okay, let's go. Let's move ahead. Okay, so you can't figure out which are important. Okay, so what I will do is I will send you the we will make the annotated PDF available. Just go through those, and wherever I have written something, where I have marked something, guys, that is the most important part. If I have left anything, I've just read through and moved ahead. Okay, you can skip that part. Okay, it is just for some extra knowledge, for some brownie points, one step, one level above. Okay, even if you leave that, it's absolutely fine. Others, wherever I have focused on, where I have told you about the basic concepts, CT, MRI, all of those are important points. Okay, need to speed up. Okay, fine, let's go. Barium contrast, guys. Okay, single contrast, double contrast. Okay, simple, don't need to know much. Single means barium only, double means two things, barium and air. Let's go. Nothing special. Hello, can you hear me now? Is it better? Is there audio? Hello, is there audio now? Okay, okay. Yes, sound not coming. Is it coming now? Is the sound coming now? Okay. Is it okay? Come on, give me a thumbs up so I can move ahead. Come on, guys, quickly. Yes, audio is back. Okay, okay, okay. Let's move ahead. Okay, so this is achalasia cardia. Remember, investigation of choice is HR, high resolution manometry. High resolution manometry is investigation of choice. Barium swallow is not the investigation of choice. Please don't mark barium swallow. This what you can see here is a barium swallow. It is not the investigation of choice. The IOC is HR manometry. So as to know the pressures, manometry basically pressure. Okay, right. Bird beak on barium enema. Okay, this is one of the questions that was asked once. It is sigmoid volvulus. Remember, bird beak on barium swallow is achalasia. Bird beak on barium enema is sigmoid volvulus. Cancer esophagus, you have to compare it, the bird beak of achalasia to the rat tail of cancer esophagus. Look at this. This is the rough part of rat tailing. This is a rat tailing of cancer esophagus. Remember, guys, the three most important MCQs of cancer esophagus, guys. The investigation of choice overall is an endoscopic biopsy. You go in with an endoscope, you pick out a piece of the lesion, and you see it under a microscope, and that is how you confirm that is an investigation of choice. Okay, investing a choice for staging, it has to be your PET CT, guys. PET CT stands for positron emission tomography CT scan. Okay, so PET is a functional scan, CT is a structural scan. You put one on one. We'll take a look at that when we study about the nuclear medicine part. Okay, very quickly, very briefly, we'll take T and N staging. Okay, so we know that staging system is a T and M staging. Okay, tumor node and metastasis. The T and N part of it, the investigation of choice for staging that in an esophageal cancer is yes. Yes, it is an endoscopic ultrasound. Okay. Yes, where were we? Okay. Yes, guys. So investigation of choice is an endoscopic biopsy. Investigation of choice for staging is PET CT, and for T and N staging, it is an endoscopic ultrasound. Let's go. DES. Look at this, guys. Look at this. Look at this. This is a nutcracker, corkscrew, or a rosary bead. Corkscrew or a rosary bead appearance of esophagus. This is seen in DES. DES stands for diffuse esophageal spasm. Okay, diffuse esophageal spasm. No, guys, you will get the annotated notes. Please don't worry. Annotated notes, you will find it. Okay, don't worry. You will get your annotated notes, guys. Please don't worry. Yes. Okay. Come on, let's move ahead. Look at this, guys. Look at this. This is the apple core deformity. Can you see? Can you see? It looks like an eaten apple. Okay, this is the apple core deformity. This is seen in your colonic cancer, specifically your left-sided colon cancer. Okay, left-sided colon cancers will give you apple core deformity. Left-sided colonic cancers. Look at this. Can you see these transverse striations in the esophagus? This is known as your, yes, feline esophagus. Feline esophagus, usually seen in GERD, eosinophilic esophagitis. Only two causes you need to remember: GERD and eosinophilic esophagitis. Okay, right. Zenker's diverticulum, guys. Look at this. Can you make out the Zenker's diverticulum here? Okay. Some people confuse it with acute epiglottitis, the thumb sign. Remember, epiglottis is somewhere here. The thumb sign is anterior. Look at this. The diverticulum is posterior. Yes, we will find the annotated notes. Please don't worry. You will get the annotated notes. Okay, don't worry about that. Please pay attention here. This is very important. Zenker's diverticulum. Okay, look at this, guys. Zenker's diverticulum. This is a lateral barium swallow. Barium swallow, again, we need to see the esophagus, and this is a lateral view. Okay. Yes. Coil spring appearance and claw sign, guys. This is seen usually in intussusception. Can you see this? Can you see this? Coil spring appearance. Okay. Coil spring appearance. This is seen in intussusception. The common MCQ's most common type of intussusception is ileocolic, guys. Which vaccine is associated? The answer is a rotavirus vaccine. Please, this was an MCQ that was asked. Which vaccine increases the risk of intussusception in children? The answer is rotavirus vaccine. Please remember, rotavirus vaccine. Okay. Yes. Clinical features: painful red currant jelly stools. Okay. Okay. This is one of the clinical features. But if it is painless, guys, remember that indicates a Meckel's diverticulum. That indicates a Meckel's diverticulum. And one point about Meckel's diverticulum that I want to ask you: which is the nuclear medicine scan or radionuclide scan that we do for Meckel's diverticulum? Come on, guys. We'll come to it later. But does anyone know which is that particle that is used for Meckel's diverticulum? Look at this. Claw sign. Okay. Claw sign. Look at this. Claw sign. Again, intussusception. Okay. Yes. Target sign, donut sign, pseudo kidney sign. All of these are signs of intussusception, guys. The most common type of intussusception is ileocolic. Remember, the ileum just intussuscepts or goes into the colon. Okay, guys, look at this. Congenital diaphragmatic hernia. Okay, congenital diaphragmatic hernia. Look at this, guys. On the left side, you can see all the bowel loops. You can see the bowel loops on the left side. Yes, you can see all the bowel loops on the left side. This is congenital diaphragmatic hernia. See where the heart has been pushed. See, the heart is pushed towards the right side. Okay, this is your left-sided congenital diaphragmatic hernia. This is known as your Bogdalec's hernia. Remember, most common is Bogdalec hernia. The mnemonic is BPL. Okay, B stands for Bogdalec. Okay, P stands for postero, and L stands for left-sided. So posterolaterally or posteriorly left-sided Bogdalec. This is the mnemonic that you need to remember. And yes, you're absolutely right. Bag and mask ventilation is contraindicated. Bag and mask ventilation is contraindicated. If there is a right-sided congenital diaphragmatic hernia, it is known as Morgagni. It is known as Morgagni. Okay. The most important prognostic factor is pulmonary hypoplasia. Pulmonary hypoplasia. Why? Because all of these tubes that are there, the gut tubes, the intestines there, the bowel, they compress or suppress on your lung development. They compress your lungs. So pulmonary hypoplasia, if it sets in, then that is a very bad, very poor prognostic factor. Okay. Right. Okay. This is the Combs sign. Okay. In Crohn's disease, not really very important. We'll move on. Okay. Abdominal TB. Abdominal TB, the most common site is your IC junction, the ileocolic junction. And look at this, guys. Look at this. What is this? What is this? And what is this? Yes. Yes. This is known as your pulled up cecum sign and the string sign. Come on, guys. Do you know this pulled up cecum and the string sign? Yes. This is the pulled up cecum sign and this is the string sign. Okay, these are the questions that have been asked for abdominal TB, that is your ileocolic junction. Okay, right. Rigorous triad. Rigorous triad is seen in gallstone ileus. Can anyone tell me? Yes, without looking. Can anyone tell me what is rigorous triad? What is rigorous triad? Come on, come on, come on. Anyone? Fast, fast. Come on, come on. We don't have much time, guys. Come on. We have a lot to cover. Come on. Not much is left though, but only the important stuff, guys. Don't worry. Rigorous triad, rigorous triad. What is rigorous triad? Yes, this is the rigorous triad. Remember, pneumobilia. Can you see air? Can you see air in the biliary tree? Okay, I'll remove these red marks so that you can appreciate properly. Can you see pneumobilia, guys? Yes, pneumobilia, air in the biliary tree. Can you see an air fluid level? Air fluid level indicating a small bowel obstruction. A small bowel obstruction because of ectopic or right iliac fossa gallstones. Gallstones are usually radiolucent, therefore not seen. But this is a triad. A radiolucent ectopic gallstone causing small bowel obstruction and pneumobilia. This is the triad known as rigorous triad, and this is seen in gallstone ileus. Gallstone ileus. Okay. Yes. Single bubble. Come on, guys. Come on, guys. Tell me. Single bubble, double bubble, triple bubble. Come on, go. Single bubble. Come on, come on, come on, everyone. Single bubble, double bubble, triple bubble. Yes, single bubble is seen in. Come on, guys. Double bubble in duodenal atresia. Okay, very good. Single bubble is seen. See, what I'll tell you a very simple, a very logical explanation about how to remember this. Okay. See, this is your stomach. Okay. This is your duodenum. Okay. Then what comes? Jejunum. Okay. Jejunum. This is the pylorus of the stomach. So if there is block here, if there is any pathology here, okay, hold on. Yes. Draw that again. So this is your stomach. This is a pylorus. This is your duodenum. This is your jejunum. Okay. Any pathology, any block here, you will see only one bubble. Okay. So any pyloric problem, any pyloric stenosis will give you only one bubble of the stomach. This is known as your single bubble. Okay. Any problem of the duodenum will give you two bubbles, one of stomach and one of the proximal part of duodenum. This is your duodenal atresia, two bubbles. Then third in line is jejunum. Any jejunal atresia will give you three bubbles. So single bubble is in pyloric stenosis. Yes. Double bubble is seen in duodenal atresia and triple bubble is seen in jejunal atresia. Remember, guys, a very important point that is asked in your pediatrics also and in medicine also and radiology also. Duodenal atresia associated with syndrome. The answer is Down syndrome. It is associated with Down syndrome. Okay. Okay. Air under diaphragm, guys, we've already seen. Okay. Air under diaphragm, we've already seen in our basics. Okay. You see it on the right side. Okay. Trends, tender, guarding, rigidity. Okay. All of these will be seen. Hollow viscous perforation, most common is bowel. Contraindication is barium. Okay. Because there is perforation. Pneumoperitoneum, guys. So air under diaphragm is one sign or the other signs. It is a football sign. Can you see all of this air that is there? Football sign. This is known as your football sign, represents the football. This is the American football, guys. Okay. Not our football. Falciform ligament sign. Normally this is a liver. Okay. This is a liver. And there's a ligament here known as a falciform ligament. Normally on an X-ray, falciform ligament is not seen. Is not seen. What happens here what happens in pneumoperitoneum is that this falciform, around this falciform ligament, there is deposition of air. There's air, right? Pneumoperitoneum. So air comes around the falciform ligament, and now you are able to see the falciform ligament. Can you see here, guys? Can you see this falciform ligament part here? Okay, can you see? Okay, so air comes around the falciform ligament, and now you can see it. This is known as your falciform ligament sign. Okay, this is known as a Doge cap sign. You can see air on the right side below the liver. Okay, in the Morrison's pouch. This is known as your Doge cap sign, and there is cupola sign. What is cupola sign, guys? Cupola sign. Can you see air? Air under the central tendon of the diaphragm. Air under the central tendon of the diaphragm. This is known as the cupola signs. And these are all the signs that you need to know for pneumoperitoneum. So air in the diaphragm was one. Football sign. Okay. Falciform ligament sign. Doge cap sign. And now we've seen the cupola sign. See? Okay. Right. Now we're taking a look at small bowel obstruction versus large bowel obstruction, guys. Okay, small bowel obstruction. Okay, small bowel obstruction. Multiple, small, and central. This is the distribution. Okay, multiple, small, and central is the distribution. First investigation, pneumoperitoneum. Who can't stand? Okay, so you can do an abdominal X-ray. You can do an abdominal X-ray in a patient of pneumoperitoneum who can't stand. Okay, abdominal X-ray you can do. Okay. Okay, so Abdullah is asking, air is black, but it's white there. Are you referring to the falciform ligament sign? Because what happens is that the black air surrounds the ligament. Now the ligament begins to appear as a white streak. Okay, that is the falciform ligament sign, guys. Falciform ligament sign, because the air surrounding it is black, the middle structure becomes white. Okay, this is because of the contrast that we see. This is your falciform ligament sign. Okay. All right, guys. Abdominal X-ray, we just saw the signs. Cupola sign, football sign. All of these are signs of abdominal X-ray of pneumoperitoneum. Okay. In chest X-ray, you see air under diaphragm. In abdominal X-ray, you see all these falciform ligament sign, football sign, cupola sign, Doge cap sign. All of these signs are seen in your abdominal X-ray. Okay. Moving on to small bowel versus large bowel obstruction. You see this. Okay. Central distribution. Large bowel is usually peripheral. Can you see this CT scan? Can you see this air? Okay, can you see air? Can you see the CT scan? It is peripheral. It is peripheral towards the periphery. Okay. Yes. This is your large bowel obstruction diameter. Okay, it is usually the 3-6-9 rule, guys. Remember the 3, 6, and 9 rule. 3 means small intestine. Okay, it means the risk of perforation is more when the small intestinal diameter after obstruction is more than 3 centimeters. 6 is for transverse colon. Similarly, the risk of perforation is more when the diameter of transverse colon is more than 6 centimeters. And for cecum, it is 9 centimeters. Okay, for cecum, it is 9 centimeters. Okay. Folds. Okay, what folds do you see? Folds here. If you zoom in, you can see that there are folds, complete folds here. Okay, if you look carefully, once you get the PDF, you will be able to appreciate it. There are complete folds here. This is known as valvulae conniventis. Valvulae conniventis is a sign of, it is usually seen in small bowel obstruction. Okay, in large bowel obstruction, you will see incomplete Haustré. Incomplete Haustré, like we saw in barium enema. Remember barium enema, large bowel, incomplete Haustrations. Right. Air fluid level, direct X-ray of small bowel obstruction, you will see more than 3 air fluid levels. Okay, see, look at this. More than 3 air fluid levels you will see. Right. And step ladder sign. Yes, you are absolutely right. Step ladder sign is also seen. Can you see? Can you make out the step ladder? Can you make out the step ladder? Yes, step ladder sign. Okay, so this is not really very important. Okay, so we'll just move on. Coffee bean appearance is usually what is asked, and the answer is usually yes, sigmoid volvulus. Okay, yes. Can you see this looks like a coffee bean? Can you see this looks like a coffee bean? Okay, because of the time constraints, we'll have to just move on and study only those which are very important. Look at this, guys. Diverticulosis. Okay, can you see sawtooth appearance? This is nothing but, see, if this is the large bowel, if this is the normal large bowel, what happens is that there is outpouching, multiple outpouching. Okay, in large bowel wall, there is multiple outpouching, and this gives the sawtooth appearance. Can you see this? Can you see the outpouching, guys? This is the sawtooth appearance of diverticulosis.
Itis means inflammation. So whenever there is pain and inflammation, it becomes diverticulitis. Okay. So diverticulosis is painless, but once it becomes inflamed and painful, it becomes diverticulitis. All right, guys? Okay. Yes. CHPS, congenital hypertrophic pyloric stenosis, very important, guys. Very important. Multiple times it has been asked, and this is the image that you usually get. There is the image that you usually get. Can you see this? Can you see this, guys? The thickened pyloric canal. Okay. Okay. Yes. So this is a USG. This is a sonography. This is a USG. The question stem will be that there is a pediatric patient, a child. He has an olive-shaped mass in the epigastrum, and he has projectile non-bilious vomiting. Okay. So what do you think of first? What do you think of first is your congenital hypertrophic pyloric stenosis, guys. Okay. Yes. So this is a USG. USG is the investigation of choice. And what is the cutoff criteria, guys, that has been asked? So the length has to be more than 16 millimeters, guys. And thickness has to be more than 4 millimeters. Okay. So this is the cutoff on USG for congenital hypertrophic pyloric stenosis. Now, can anyone tell me what is the ABG or the acid-base abnormality that you see in CHPS? Yes, that is a very important surgery question that you get on CHPS and a pediatric question. Come on, guys. What is it? What is the acid-base anomaly that you get? Okay, right. So this is what you see on a barium meal. You can see the stomach, you can see the proximal duodenum. This is a barium meal. Okay, barium meal, you can see the various signs, the mushroom sign. Okay, the teeth sign, shoulder, the beak sign. Okay, the question that was asked was, which of the following signs is seen on barium meal? And which of the following sign is not seen on USG? So if you remember these names, you don't need to go into the detail of what it is. Just remember the names that these signs are seen on barium meal. Okay. Yes. Hydrated cyst. Remember, guys, I showed you a photo, remember, of hydrated cyst. Hydrated cyst organism is Echinococcus granulosus. Most common site is liver more than lungs, and man is an accidental dead end host. Remember this. These are the only three things that you need to know. One important surgery point of view question that they ask is this photo. Can anyone tell me what is seen in this photo? Anyone? What can be seen in this photo, guys? Come on. Come on, guys. I'm waiting. Yes, yes. What is seen in this photo, guys? Come on, fast. Fast, guys. We don't have a lot of time. Come on. What is seen in this photo? Yes, lily. Yes, it is the water lily sign, guys. Water lily sign. It is the water lily sign. Okay. Moving on. Focal liver lesions. Okay. Investigative choice is a multi-phase CT scan. That is an MCQ if you want to remember. The question that is usually asked is how do you differentiate between a hepatocellular carcinoma from METs? Okay, on a CT scan. So what happens in arterial phase? Multi-phase, there are three phases: arterial, portal vein, and delayed phase. Arterial phase, the HCC will show enhancement. The metastasis will not. One point you need to remember. Okay. Second point you need to remember is the background liver will be cirrhotic in HCC. Guys, remember HCC is a chronic manifestation. Chronic hepatitis and cirrhosis and then HCC. The entire liver is usually cirrhotic. But in metastasis, it is usually normal because liver is just a bystander. Okay. The cancer has come from somewhere else. The rest of the liver remains normal. And these are 2 points I need to remember for metastasis. Fibrolamellar HCC, guys. Fibrolamellar HCC. Young males, central stellate scar. Can you see this? Can you see this? Young male, central stellate scars. These are the 2 points, fibrolamellar variant of HCC. Amoebic versus pyogenic liver abscess. Amoebic single, usually right lobe of the liver. Pyogenic, multiple coalesced lesions. Okay, throughout the liver. They can be distributed. Okay, moving on. Moving on, guys. Fast, we'll move on fast. Gallstones, like I said, guys, come on. Come on, gallstones. Do you need me to explain? Right? Come on, you explain to me. What do you see here? What do you see here? Come on, guys, gallstones. Come on, fast. You've seen this again. Come on, guys, gallstone. Yes, posterior acoustic shadow. Can you see this white with posterior acoustic shadowing? This is how you differentiate a gallstone from a polyp. From a polyp. Okay, now this is important. This is important. Adenomyomatosis. Remember, guys, adenomyomatosis
Okay, this will show you something known as comet tail artifacts. Can you see this? These are nothing but comet tail artifacts seen in adenomyomatosis, and that is all you need to know. Moving on, porcelain gallbladder. This was a question asked, and this was the photo that was given, guys. Porcelain gallbladder means calcification. You see a calcified rim around the border of the gallbladder. Can you see this? Can you see this calcified rim, guys? Can you see the calcified rim? Yes? Come on, come on. Why is this important, guys? Come on, tell me. Why is porcelain gallbladder important? Why? Because there is increased risk of adenocarcinoma. Remember, guys, there is an, yes, just a minute. Yes, there's an increased risk for adenocarcinoma in porcelain gallbladder. Okay? Come on. Look at this, guys. Look at this. Can you see one small indentation on the gallbladder? Can you see this? Can you see this indentation on the gallbladder? Come on, come on. Tell me yes. Or send a thumbs up. Come on. Can you see an indentation on the gallbladder? This is a normal variant, guys. This is a normal variant. Normal variant. This has been asked. This is known as a Phrygian cap. This is known as a Phrygian cap. Come on, guys. Come on, send a thumbs up. Can you see? Can you see Phrygian cap? Yes. Come on. This image is of an MRCP, please. MRCP is an investigation of choice for choledocholithiasis, means stone in the CBD, stone in the common bile duct, choledocholithiasis. MRCP is the investigation of choice. Okay. What is the gold standard? It is ERCP, endoscopic retrograde cholangiopancreatography. Why ERCP is not investigation of choice? Again, because it is invasive. MRCP is not invasive. MR stands for MRI, magnetic resonance. Okay, it is a T2 weighted imaging. Remember, it is a T2 weighted imaging. Okay, this is MRCP. Remember T2, World War II, water appears white, bile is water. Can you see bile? Okay, this is a biliary tree with bile, and you can see World War II, bile appears white. Are you able to link everything, guys? Are you able to link the basic concepts? Okay, come on, tell me yes or no, come on. Is it going fine? Come on, guys, is it too much? Tell me. I'll adjust accordingly. Come on, guys, we don't have much time. We still have some bit to cover. Come on, tell me. It's already 3 hours. Is it fine? Okay. Yes, it will be a little long, but I promise you, you will not need anything more than this. I promise you that. Okay. Okay, fine. We'll skip whatever is not really necessary. We'll only touch upon the most necessary parts. Come on, let's go. Okay. Chronic calcific pancreatitis. Remember what is asked in ERCP. You have chain of lake appearance. Okay. This is what's asked. This is what's asked. ERCP. Genitourinary system, guys. Come on. We are done with the GIT. Now we move on to the GUT. Genitourinary system, guys. Okay. We are towards the end. Come on. Maximum. Max to max. We'll take another 30 to 45 minutes and we'll be done in less than 4 hours, guys. Okay. Come on. Let's go. So genitourinary system, IVU. IVU stands for intravenous. Okay, intravenous urography. Yes, tube is present in ERCP, therapeutic and diagnostic. You're absolutely right. You're absolutely right. So IVU, what happens is that we inject the contrast. The contrast gets filtered through the blood, artery, kidney, and passes through the urine. Okay, so we inject in the arm, we inject the contrast. Contrast goes via the circulation, renal artery, in the kidney, gets filtered in the urine, and comes out to the urine. Okay, look at this, guys. Look at this. This is a flower vase or the handshake sign. Can you see? They're trying to shake hands, the chalices. They're trying to shake hands behind the vertebra or in front of the vertebra. Okay, they're trying to shake hands. What does this mean? This means that the lower poles of the kidney are fused. Therefore, the chalices are moving towards each other. And what is this? Yes, wonderful. Okay, yes, this is horseshoe kidney and Turner syndrome. Yes, investigation of choices, CECT, guys, CECT. Okay. Yes, CECT. Moving on. Cobra head or adder head appearance, guys. Look at this. Look at this. Cobra head or adder head appearance. This is seen in ureterocele, guys. Ureterocele. Okay, ureterocele. This is another important question. Okay. Yes. We'll do only what's most important, guys. Come on. We'll skip what is less important. Okay. Look at this. The hooking of the ureter. Can you see on the right side there is hooking? Okay. This is known as your retrocaval. Fish hook sign in retrocaval ureter. Okay, fish hook sign in retrocaval ureter. Okay. Putty kidney. Guys, this is important. Please pay attention here. Putty kidney was a question. And this image itself was given. Putty kidney. Okay. Can you see this? Chunky lobar calcification. This is the end stage of genitourinary TB. This is nephrocalcinosis. Calcium deposits in the kidney, especially in the medulla. Okay. So this is usually unilateral, putty kidney. This is usually bilateral. Can you see in the image? Can you see in the image? Putty kidney is usually unilateral. So how do you identify chunky deposits? History of genitourinary TB, unilateral. This is usually putty kidney, and medullary calcification, usually bilateral. This is usually, yes, nephrocalcinosis. Okay. Vesiculated grading. Okay, guys, I think you have studied this in your surgery as well as a pediatrics, so we will not go into this. Posterior urethral valve is again very important. Again, you have studied in your surgery. It is the most common congenital cause of urinary retention seen in males. Antenatal, you have the keyhole sign associated with Potter's sequence. Potter's sequence, oligohydramnios. Remember, because there is posterior urethral valve, the baby, the male patient cannot pee out the amniotic fluid. Therefore, there is oligohydramnios, Potter's sequence, again, pulmonary hypoplasia. Okay, can you connect all of this? Can you link all of this? Yes. Okay. Urethral injury. Guys, urethral injury is very important, so please pay attention. We'll take this slow. Urethral injury. Urethral injury, what the question stem will be like, that there is a pelvic injury or there is a straddle injury. Remember, pick up these words, guys. Pelvic injury or straddle injury. Number one. Number two, there is difficulty in passing urine, guys. Okay, just a minute. Yes. Decrease urine output. There is difficulty in passing urine. And third, there can be blood at tip of meatus. Blood at meatus. Okay, guys, if you see these three or any two out of these three, then you start thinking about urethral injury, guys. Okay, urethral injury. Come on, yes. What is the investigation of choice for urethral injury, guys? Come on. Tell me. The investigation of choice for urethral injury is, yes, it is something known as RGU, retrograde urethrophy. Okay, you do not do a micturating sister urethrogram. MCU is not done. RGU is done. Okay. Yes, RGU is the investigation of choice. But what if a patient is unable to pee? Like I said, the patient, there's difficulty in passing of urine. So urine accumulates in the urinary bladder. So what do you do about that? Okay. So if the bladder is palpable, you do a suprapubic cystostomy. If it is not palpable, you wait and watch. Okay. Right. Okay. Bladder injury, only 2 points you need to know. If there is an extraperitoneal rupture of bladder, conservative management. If it is an intraperitoneal rupture of bladder, means the urine has gone into the peritoneal cavity, then you need to explore and do surgery. Okay. Pear-shaped bladder, okay, seen in pelvic hematoma lymph nodes. So what happens is that there is hematoma here, and it is compressing the urinary bladder. It has become pear-shaped, and that is it about. Okay, that is about pear-shaped bladder, is nothing more. Thimble bladder, can you see? The urinary bladder is irregular. It is constricted. It is small. Guys, thimble bladder is seen in what? Come on. Tell me. Thimble bladder is seen in what? Again, which infection? Thimble bladder is seen in which infection? Come on, guys. Come on. I know you guys might be tired, but we are towards the end. Trust me. We are towards the end. Come on, tell me. Thimble bladder is seen in what, guys? Come on. Thimble bladder is seen in? Yes, it is seen as end stage of tuberculosis, guys. Thimble bladder is seen in tuberculosis. Calcification of bladder, can you see? The walls of the bladder are calcified. Can you see this? Thin rim of calcification. Schistosomiasis. Can you see this? Spiculated stone, urinary bladder stone. Investigation of choice. Guys, investigation of choice of urinary bladder stone. Come on, tell me. Investigation of choice of a urinary bladder stone, guys. Come on. We've talked about it. All stones except gallstones. Investigation of choice is, it is an NCCT, guys. It is a CT scan. Right. Look at this Christmas tree bladder. Can you see Christmas tree like appearance of the bladder? See in? Yes, neurogenic bladder. Okay, moving on. Okay, we'll finish this, guys. Again, renal stone, investigation of choice is an NCCT. Okay, calcium oxalate is the most common type, and the hardest is cystine. The hardest stone is cystine. It is difficult to break. Okay, the most common is the calcium oxalate. Look at this, the stag horn. Have you seen the stag horns? Okay, the stag horns on the animal. Okay, this represents the stag horns, the stag horn calculus made of struvite, precipitates an alkaline urine. Okay, and it is seen because of urease producing organisms like Proteus and Klebsiella. Remember, guys, remember this is an important part. Okay, this is important. Okay, Proteus and Klebsiella, urease producing organisms. This is your stag horn calculus. NCCT, again, I told you, for all stones except gallstones, the investigation of choice has to be NCCT, guys. Come on, moving on. Okay, this is a clear cell renal cell carcinoma. Can you see this? Can you see? There is a classical triad of renal cell carcinoma. Okay, there is an abdominal mass. Abdominal mass can be there. Hematuria, second point. And third is pain radiating from loin to groin. Okay, have you heard of this? Have you heard of this? Okay, I'll write the organisms, guys. I'll write the organisms. Yes. So urease producing organisms like Proteus and Klebsiella. Okay, Proteus and Klebsiella. Right? Okay. Cancer, clear cell renal cell carcinoma. Like I said, there is a triad of renal cell carcinoma. The triad is an abdominal mass, abdominal pain radiating from loin to groin, and hematuria. Okay, if you see any of these three in the question stem, start thinking about renal cell carcinoma. Now, one important point that I would want to ask you, this renal cell carcinoma is a clear cell type. This is the most common variety of renal cell carcinoma. It is associated with a syndrome. What is that syndrome known as? Come on, guys, what is that syndrome? Yes, it is von Hippel-Lindau syndrome, guys. Von Hippel-Lindau syndrome. It is associated with, yes, clear cell type of renal cell carcinoma. On histopathology, can you see these clear cells? Can you see these clear cells? Okay. Yes, most common type, most common variant of renal cell carcinoma. Okay. Chromophobe RCC, guys. Chromophobe RCC. It is associated with tuberous sclerosis and Birt-Hogg-Dube syndrome. Just remember these points. It is associated with which? Okay, so one point I'll tell you. VHL, clear cell. Any other syndrome, tuberous sclerosis or whatever, has to be chromophobe. Okay, just remember one. Okay. Angiomyolipoma, guys, look at this. Angiomyolipoma means multiple densities will be seen. Okay, this is CT scan. Can you see? The cortical bone is white. So densities, multiple densities. Can you see this is black? Can you see this is gray? Can you see this is white? Can you see this is black? This is gray. This is white. So angiomyolipoma. Angio means blood vessel. Myo means some muscle. And lipoma. Lipo means lipid or fat. Okay, so multiple components, multiple densities. Angiomyolipoma. Okay, this is associated with a syndrome known as Wunderlich syndrome. Okay, I've written it for you guys. Wunderlich syndrome. Wunderlich syndrome shows the Lenz triad, which is acute abdo pain, shock, and palpable mass. This is a very important question from surgery point of view, guys. It has been asked once. Surgery point of view. Okay. Yes. Okay. OBGYN and breast pathology. Okay. 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 We'll just breeze through because you've already studied this in OBGYN. So we'll just look at it. The first sign is the intradecidual sign. Okay. The second one is a double decidual sac sign. Now remember, intradecidual sign is one of the first reliable signs of a decidual pregnancy or a pregnancy within the uterine cavity. Yes. Can you see the double decidual sac sign, guys? Can you see the two sacs? Yes. Can you see the two sacs? Come on. Yes. We just breeze through. Come on. Yes. This is the yolk sac. The next is the yolk sac, the double bleb. Can you see the double bleb, guys? Can you see the double bleb sign? This image has been asked multiple times. The question is, what is this sign? What is this sign? What does it represent? It is the double bleb sign representing the intrauterine pregnancy, guys. Okay, look at this, guys. Look at this. Come on. Can anyone tell me what this is? Can anyone tell me what this is? This image has also been asked multiple times. Come on, guys. What is this? Come on, guys. Just half an hour, 45 minutes to go max. Come on, guys. What is this? What is this? Come on, tell me. Tell me. Tell me, what is this? What is this? Anencephaly? No. This is not anencephaly. Look at it. Look at it. It's written NT. NT means nuchal translucency. Okay. So behind the occipital region of the baby, can you look at this black area? Can you look at this black area? This is a nuchal translucency. Nuchal. Nuch means neck. Nuchal translucency behind the neck region. Look at this, guys. The translucency here, there is minimal. Look at this lucency. It is widened or enlarged. If it is more than 3 millimeters, guys, there is an increased risk of which syndrome, guys? Which syndrome? Come on. aneuploidy. Yes, aneuploidy with syndrome, but Down syndrome, guys. Okay. Yes, Down syndrome. Okay, ectopic pregnancy, ring of fire on duplex. Okay, just remember this image. Just remember two words: ring of fire on duplex, ectopic. Moving on. Frog's eye sign. Yes, guys, this is important. Look at this. Look at this. Can you make the connection? Can you see the frog's eye sign? Yes, this is seen in anencephaly. Anencephaly, very, very, very important because of 2 points. Number one, frog's eye sign. Number two, the earliest anomaly to be detected on USG. The earliest anomaly to be detected on USG by 10 weeks of gestation is anencephaly. Okay. Look at this lemon sign. Lemon sign, sorry. Lemon sign. Can you see? This is like the lemon, and there is indentation. There's indentation of the frontal bones. Can you see this indentation? Yes, flattening or indentation of the frontal bones. This, along with another sign that is known as the banana sign. Can you see this is the wrapping of the cerebellum? The cerebellum has wrapped around the brainstem. These two signs indicate what? They indicate an open spina bifida defect. Indicate an open spina bifida defect, like an Arnold-Chiari malformation type 2. Okay, open spina bifida defect. This shows lemon sign and banana sign. Okay. Okay, so all of this I think you'll cover in gynec. I think we should skip through. Do you want me to just skip through this? DCDA, MCDA, the twin peak sign, the lambda sign, all of this will be covered in gynec. Do you want me to go through it or do you want me to skip it? Come on, fast. Tell me, come on. What do you want me to do? Fast, come on. Do you want me to talk about it or skip? Okay, skip. Skip. Okay, we'll move on. Okay, just one important point, guys. Just remember this, the table. Investigational choice for Mullerian anomalies. Okay, 3D USG more than MRI. Gold standard is laparoscopy plus hysteroscopy. HSG. Okay, just 2 points. Just 2 points I need to remember. Bicornuate and septate. How to differentiate bicornuate? Remember, bi means big angle, bada angle. Look at this angle, guys. The angles between the two horns. Look at this angle. Hold on. Okay. Yes. Look at this angle, guys. Look at this angle. Do you think this angle is more than 90? Yes, it is more than 90. It's usually more than 100, 105. This bada angle or big angle represents bicornuate uterus. Look at this, guys. Look at this. Do you think the angle is more than 90? Do you think the angle is more than 90? No, it is not. It is less. It is less. Usually less than 75. This is known as septate uterus. Okay. PCOS, again, guys, PCOS, come on. Peripherally arranged. Look at this. Peripherally arranged follicles. There is no single dominant follicle. The updated criteria, remember, more than 20 follicles have to be there. String of pearl appearance is called string of pearl. Compare it with OHSS, ovarian hyperstimulation syndrome. Ovarian hyperstimulation syndrome. Look at PCOS, how they're peripherally arranged properly. Look at this. This is randomly arranged. Large size follicles. History of IVF. History of IVF is very important. This is ovarian hyperstimulation syndrome. Okay, right. Okay, tell me. This combination is seen in what? Come on, guys. This combination is seen in what? Bilateral thecal lutein cyst and snowstorm appearance. Very common. Come on, tell me. Come on. This is seen in what? Come on, guys. This is seen in something known as complete mole, guys. Complete hydrated deform mole. Okay, complete mole. Okay, this is seen in complete hydrated deform mole. Breast, yes, popcorn calcification, fibroadenoma. We all know that. Popcorn calcification, fibroadenoma. Breast implant rupture. All right, guys, breast implant rupture. I think you have studied this in your surgery classes also, right? So there is an intracapsular rupture and there is an extracapsular rupture, guys. Intracapsular rupture and extra. If it is an intracapsular rupture, remember, intracapsular rupture on MRI, what you see is known as a linguine sign. Linguine sign. On USG, what you see is a stepladder sign. We've also seen stepladder sign in small bowel obstruction, guys. Okay, on ultrasonography is a stepladder. On extracapsular rupture, snowstorm appearance. Snowstorm appearance, bilateral thecal lutein cyst, complete molar pregnancy. Okay, complete hydradiform mole. Okay, yes. Musculoskeletal, guys. Musculoskeletal, the first investigation that you do is an X-ray. For bone cortex, like I said, cortical fractures, it is CT.
bone marrow, MRI. Okay, any bone marrow like avascular necrosis, stress fracture, or even acute osteomyelitis, the investigation of choice has to be MRI. Bone mineral density, DEXA scan. DEXA stand for dual energy X-ray absorptiometry. Okay, look at this normal. This has been asked, guys. Look at this continuous. Look at this continuous green line. Can you see? This is known as the Shenton's line. Okay, from the inferior margin of the neck of femur, okay, to the inferior margin of the superior pubic ramus. This continuous line, this is known as the Shenton's line. Okay, Shenton's line. If it is broken, it can indicate fracture. Okay, okay. Coming to, yes, the carpal bones. Few MCQs on carpal bones. The last to ossify is pisiform. Where is pisiform, guys? Where is pisiform? From lateral to medial. Do you know the mnemonic? From lateral to medial. From thumb to little finger. She looks too pretty. Try to catch her. Scaphoid, lunate, tricutal, pisiform. Try to catch her. Trapezium, trapezoid, capitate, and hamate. Okay. So pisiform is the last to ossify. Which fracture of which carpal bones presents as pain or tenderness in the anatomical snuff box? Come on, guys. Anatomical snuff box, pain and tenderness. Fracture of which bone? Fracture of which bone? Fracture of which bone? Come on, guys. Fracture of which bone? Scaphoid. It is scaphoid. Scaphoid fracture. Okay, scaphoid fracture. Asked in ortho. Acromegaly. Signs of acromegaly. Heel pad thickness more than 20. Can you see? Can you see on X-ray the heel pad thickness is more than 20? Can you see a spade phalanx? Have you seen that instrument called a spade? Can you see the spade phalanx here, guys? Spade phalanx. And frontal bossing. Can you see the frontal bossing? All of these are features of acromegaly, guys. Acromegaly. Hyperparathyroidism. Can you see the Brown's tumor? Look at this. Look at this lytic lesion here, guys. Can you see the tumor? It is not actually a tumor. It is just a lytic lesion, okay, of hyperparathyroidism. Parathyroid has increased. It takes up calcium. Calcium is gone, and there is nothing else left but lytic lesions, okay? Similarly, in skull, you get the salt and pepper appearance of skull. Okay? Yes. Rugger Jersey spine, guys. Rugger Jersey spine. Look at this. Look at this. Can you see white, then black, and then white? This is white. This is black. This is white. This is known as Rugger Jersey spine. This is a Rugger Jersey. This is seen in renal osteodystrophy, guys. Rugger Jersey, renal osteodystrophy. Fluorosis, guys. Fluorosis are very important. Can anyone tell me what this is? Can anyone tell me? This has been asked once. This has been asked once. Can anyone tell me what is this sign seen in fluorosis? Come on, guys. Come on. I'll give you a hint. There is something happening in the membrane between the two bones. Interosseous membrane is being affected. What is it? What is happening? Come on. It's very specific, guys. Very high yield. One look and you'll know the answer that this is fluorosis. What is happening, guys? Yes, absolutely brilliant, Abdullah. This is calcification of interosseous membrane, classically seen in fluorosis. Paget's disease, again, cotton wool spots can be seen. Okay, so Paget's disease, a lot of pointers or a lot of spotters are there. Again, you study all of this in orthopedics also. Okay, I'm just touching upon all the points. Picture frame vertebra. Can you see this vertebra? And this is a picture frame vertebra. Ivory vertebra. Can you see this vertebra is completely white? It's completely white. This is ivory vertebra. Blades of grass. Can you see this lesion? It is like a blade of grass. All of these are signs of Paget's disease. Yes. Achondroplasia. Achondroplasia. Can you see the bullet-shaped vertebrae? Can you see the bullet-shaped vertebrae, guys? Look at this. Look at this. Can you see the bullet-shaped vertebrae? Okay. Champagne glass pelvis. See? Look at this. Does it represent a champagne glass? Champagne glass pelvis. And the chevron sign. Can you see a notch here? Can you see a notch here? This is a chevron sign. Okay. All of these are signs of achondroplasia. Achondroplasia. Okay. Trident hand. Trident hand. Come on. It is seen in what? Trident hand is seen in which disease? Come on, guys. Come on. Come on, answer. I know you're tired, but we're towards the end. Okay. We're ending it very soon. Tell me. Trident hand. Trident hand is seen in which disorder? Come on, guys. Anyone? Let's go. Come on. Trident hand is seen in which disorder? Come on, guys. Yes, it is the same. It is achondroplasia, guys. Achondroplasia. Polka dot vertebrae. Look at this. Polka dot appearance. It is seen in hemangioma, vertebral hemangioma. Let's go. Nothing else you need to know. Okay, look at this. Ochronosis or L-captonuria shows you something. What is this? What am I trying to highlight, guys? Come on. Come on, tell me this. What am I trying to highlight? Scurvy, you will see the signs of scurvy. Abdullah will just see the signs of scurvy, and then you'll know what signs we see in scurvy. Chevron sign is usually associated not with scurvy. Okay, it is not associated with scurvy. Come on, guys, tell me. What am I trying to show you? What is this? Come on. Ochronosis, alkaptonuria. This shows calcification of intervertebral disc. Please, this is very important. Calcification of interosseous membrane is fluorosis. Calcification of intervertebral disc is ochronosis or alkaptonuria. Okay. Again, picture frame vertebra, ivory vertebra. We've seen Paget disease, cotton wool. Again, we've seen Pagets. Okay. Salt and pepper, we've seen parathyroidism. Raindrop or punched out lesions. Look at this. Can you see the raindrop lesions? Can you see the raindrop lesions? Yes, this is classical of multiple myeloma. Raindrop, multiple lytic lesions, multiple myeloma. Multiple myeloma, guys. Do you remember the CRAB criteria? CRAB criteria. Yes. Calcium, renal failure, anemia, and bony lytic lesions. Do you see the bony lytic lesions here? Yes, CRAB criteria of multiple myeloma. Hair on end. Come on, guys. Do you know this? Have you seen this? Come on, everyone knows this. What is this? Hair on end appearance or crew cut appearance or sunburst appearance of the skull. This is seen in, yes, any hemolytic anemias like sickle cell anemia. Sickle cell anemia. Yes, any hemolytic, sickle cell thalassemia, it can be seen. If there's excessive hemolysis, there's excessive erythropoiesis going on, you can see the, yes. See, raindrop, salt, pepper, no one will ask you to compare and tell you which one it is. Okay, it is just in the clinical background that you see. Or if there's a direct question that is asked, that raindrop is seen in what, or salt and pepper is seen in what, then you have to say, okay, no one is going to ask you. If they want to ask you about the raindrop of multiple myeloma, they will give you a history of an elderly person having joint pains, okay, having some urinary problems are there, anemic, he is anemic, calcium is elevated. So all of these CRAB criteria, you have to match all the pointers, and then you come to a diagnosis of multiple myeloma based singly on the skull appearance of raindrop or punched out lesions or salt and pepper appearance or geographical lesions. These are usually not the type of questions asked, but they can be direct questions. Therefore, we're trying to cover it. And these are named signs which have been asked before. Okay. Go. Tumors. Okay. Epiphysis tumors, chondroblastoma, giant cell tumor, metaphysis and diaphysis tumors. Okay. Again, guys, you studied all of this in orthopedics. We'll just move on. Okay. We'll just move on. Yes. Look at this giant cell tumor. It is seen in adults. Why adults? Because I cannot see the growth plate. The growth plate has fused, and this is giant cell tumor. Okay. Look at this, guys. Child, the growth plate is not fused. Okay. Chondroblastoma. Look at this. This is the simple bone cyst, guys. SBC stands for, yes, SBC stands for simple bone cyst. Guys, this is a very important image. Please take a look. Simple bone cyst. Most common site is proximal humerus. Can you see this is the proximal humerus? Okay. Can you see that this is the proximal humerus? Can you see this lesion? Yes, it's a simple bone cyst. Now the arrow is pointing to something. What is the arrow pointing to? The arrow is pointing to this small piece of bone. Can you see, guys? Can you see the arrow? Yes, this is a pathological fracture of the bone, and the bone is moved inwards and is hanging. The bone is hanging. This is known as a trapdoor sign. This is known as the trapdoor sign, guys. Okay. Yes, trapdoor sign. And once if this breaks from here and falls down, it comes lying here. This is known as the fallen leaf sign. Fallen leaf sign. Okay. Yes. Again, aneurysmal bone cyst. Okay. Aneurysmal bone cyst. Simple bone cyst, aneurysmal bone cyst. More important is simple bone cyst. Osteosarcoma. Guys, osteosarcoma. This is the classical picture. You just cannot miss osteosarcoma. Okay. Most common primary malignant tumor of the bone. Osteosarcoma. Guys, there are two confusing MCQs. Most common tumor or most common malignancy of the bone. Most common malignancy or most common tumor to be found in the bone. It is not osteosarcoma, it is metastasis. But if they ask you what is the most common primary malignant tumor, then it has to be osteosarcoma. Okay. What is the most resistant, radio-resistant tumor? It has to be osteosarcoma. Can you see the sunburst appearance? Can you see the sunburst appearance? All of this is nothing, but it's just a periosteal reaction, guys. It is just a periosteal reaction. And then you find something known as Codman's triangle, also part of periosteal reaction. Enchondromas. Can you see this? Can you see this? Enchondromas. These are usually found in phalanx. Where phalanges, multiple enchondromas is known as Ollier syndrome. And if enchondroma is associated with hemangioma, it is known as Maffucci syndrome. And that is all you need to know. Exostosis. Can you see this? Growth. Exostosis, guys. Exostosis has a risk of chondrosarcoma if the cartilage cap is more than 2 centimeters. Okay, that is a risk factor. Osteoid osteoma, guys. Osteoid osteoma is the most common true benign lesion or true benign tumor of the bone. Okay, usually seen in the history will be of a young male, a young child. Okay, has severe bone pains, especially at night, and classically relieved by aspirin or NSAIDs. Okay, classically relieved by aspirin or NSAIDs. Night pain in the bone, young child, male child. On imaging, you see a central nidus. Okay, you see this. Okay, you see a central nidus, and this is nothing but osteoid osteoma. Right. Ewing sarcoma, guys. Ewing sarcoma, CD99 or MIC2. CD99 or MIC2. Okay, pathology point of view. Chromosome T11 and 22 it is. Okay. Yes. Radio and chemosensitive. Onion peel periosteal reaction. Chondrosarcoma. The most common question asked is flat bones, elderly, and popcorn or speculated or stippled calcification. Okay. Yes. Metastasis, guys. Metastasis. If unilateral metastasis, you can see the winking owl sign. If unilateral metastasis, you can see the winking owl sign. Okay. Bilateral metastasis, you can see the blind vertebra sign. You can see the blind vertebra sign. There is no pedicle. Okay, here there is pedicle, but here there is no pedicle. Bilateral pedicle involvement, blind vertebra sign. Yes. Metabolic bone diseases, guys. This is curvy. Again, you've done it in ortho and pediatrics. Rapidly going through. Okay. This is the tremor field zone. Can you see this black area? This is a tremor field zone. This is a pencil thin cortex. Pencil thin cortex. Can you see this spurring at the edge? This spurring is the Pelkan spur. This is the Wimberger's ring sign. Okay. This is your provisional zone of calcification, the white area. And the black area is the tremor field zone. Tremor field zone. These are the signs of scurvy that you need to know, guys. Okay. These are signs of scurvy. And you need to know how to differentiate scorbutic rosary from a rachitic rosary. Scorbutic rosary from a rachitic rosary. Which one is painful? Come on, tell me, guys. Which one is acute angled and which one is painful in the ribs? You get rosary, right? Scorbutic versus rachitic. In rickets and scurvy, in both you get. Which is painful? Which is more acute angle? Come on, tell me. Okay. In rickets, okay, you get the fraying, cupping, and splaying sign. The classical. Can you see? Fraying of the border and there's cupping. Fraying, cupping, and splaying. What is splaying? Look at this. Look at this. Look at the ends. It is splaying. It is widened. It is splaying. It is widened. Why? Because there is no mineralization. There's no deposits because vitamin D is not there. This is seen in rickets. First sign of rickets is loss of provisional zone of calcification. Osteomalacia, pseudo fractures. Okay. Okay. Moving on. Onto the most important parts. Codfish. Look at this. Look at the vertebra, how it is. Okay. A codfish or a fish mouth vertebra seen in osteomalacia more than osteoporosis. Okay. Yes, Abhijit, you're right. Scorbutic rosary is painful. It is acute angle and painful. Rachitic rosary is usually not painful. Yes. Wedge fracture. Look at this. Look at how the vertebra is. Okay. Normally vertebra should be square, but look how this vertebra is. Okay. There is a wedge compression fracture. This is osteoporosis. H-shaped vertebra, guys. Look at this H-shaped vertebra. Can you see this H-shaped vertebra? H-shaped vertebra is seen in. Yes, come on. Tell me. Tell me. H-shaped vertebra. We've also seen this in hair on end appearance or crew cut appearance. This is seen in. Come on. Hair. H-shaped vertebra is seen in, guys. Come on. H-shaped vertebra is seen in sickle cell, guys. It is seen in sickle cell. Yes. Look at this, guys. Come on. Can anyone tell me what this is? Just identify. Just tell me what this is. Come on. Anyone? Come on, we're towards the end. These are the last 2 pages. Last 2 pages. Come on, guys. All those are sleeping, please get up for a moment or two. We're towards the end. Tell me what this image is. What is this investigation? We've spoken about it, guys. We've spoken about it. What is this investigation? Remember, whenever you see this orange image showing multiple areas which light up of increasing uptake, an orange image This, remember guys, this is nothing but PET CT. This is PET CT. This is PET CT, guys. Okay, you can see the bones, cortical bones, they're white. This is CT. Okay, this is the PET. This is a functional imaging. PET is functional imaging, CT is structural imaging. So we superimpose PET on CT. This becomes PET CT. This becomes PET CT. Okay, right, PET CT. Okay, what you need to know about PET CT is, what is the principle? What is the principle of PET CT? Yes, come on guys, anyone? Okay, I'll tell you. It is annihilation coincidence circuit. That is the first question. The second question, what element is used? Come on guys, what do we use for PET CT? What element, what molecule is used for PET CT? Come on guys. What element is used for PET CT? Come on. Yes. What element is used in PET CT? It is 18 FDG PET, 18 fluorodeoxyglucose. 18 fluorodeoxyglucose. The MCQ point is, what is the T half? The T half is 110 minutes, 110 minutes. Okay. Yes. Okay. PET CT is used for cancer staging, cancer response. Okay. Yes. Cancer staging, cancer response, and recurrence. Okay. Yes. The last image of the day, guys. The last image of the day. This is an iodine scan. This is an iodine scan. Okay. Iodine scan. Do you know what are the isotopes of iodine? Yes. Isotopes of iodine. Remember, iodine 123, iodine 125, iodine 131. Okay. How to remember what they're used for? Remember ABD. You know ABD, Williams? Right? ABD. This is for ablation. Ablation. This is for brachytherapy. Brachytherapy. And this is for diagnosis. So the scanning that you see is diagnostic. Iodine 123. Okay. Okay. Right. So this is what you see is a diffuse increase uptake. Diffuse increase in the uptake. This is Graves. This is Graves disease. And diffuse decrease in the uptake. Diffuse decrease in the uptake is seen by, it is seen in thyroiditis. It is seen in thyroiditis, guys. Okay. Thyroiditis. One more important point that guys you need to remember. There's a scan known as DMSA scan. Remember DMSA, S stands for scarring. This is used to identify any scars in the kidney, scarring. Okay. Then there is a scan known as DTPA scan, guys. P stands for physiology. So for physiological functioning of the kidney, we use the DTPA scan. DTPA scan. And one question that I asked you in Metis diverticulum, what was the element or the molecule that we used? And that was technetium 99 per technate scan. Per technate scan. Okay. Okay. Yes. So you think we should stop, guys? Yes. So we've covered almost everything that you need to know. Yes. Yes, Abdullah, we've covered almost everything. We've covered the basics. From the basics, we've taken a look at some levels of MCQs that can come. Okay. We've taken a look at one step above MCQs also that can come, that may come. Okay. So as to give you an edge. All right. If you have any doubts, you can always reach out to me. Yes. 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 Any doubts? Anyone has any doubts? Come on. Anyone has any doubts they want to ask me? Okay. Okay, if there is no doubt, then I think we shall end the session. It's exactly 4 hours, I guess, right? We've completed almost everything. Okay, so one-liners like which ions are used or anything important. Okay, I'll just put in a table in the PDF if that's what you want. Usually you'll have to do ratification of that. I'll just add in a table if you want. Okay, there's no explaining. You'll just have to learn it and mug it up. Okay, so that's the reason I didn't put it up here, because there's no explaining needed. Okay, and it is barely asked. So if you still want it, I'll put it in the PDF and I'll send it. Everything important I've already covered. See, Technician 99 I've covered, DTPA, DMSA, FDG PET. This is what is usually asked. Okay, one effect name the cancer cells show is a Warburg effect. So all of these things, are actually important. That has already been covered in FDG PET. What is the T half 110 minutes? So these are the questions that are asked. The photo is given. Any orange photo you see, usually it is an FDG PET. Okay, I guess so. That's about it. That is all from my side. If still anything is remaining, any doubts, you can always put it in the comment section and I'll try to get back to you. Yes, add the tables of investigation of choice. Yes, I'll do that. Investigation of choice. We've already studied in which situations NCCT will be, in which situations MRI will be, but I'll still tabulate it and I'll put it towards the end. Okay. How many questions can be without integration and with integration? See, a total radiology questions around 15 can come. It will be a mixture of with and without integration. So if you look at one-liners, pure one-liner radiology questions, they can be around 6 to 7. Their numbers have been reduced. Integration is the way. Okay, so linking of the system with surgery, pediatrics, all of that is the way forward with OBGY, with ortho, right? So that is how you have to study. Integration is the key. Okay. All right. Chalo. Bye-bye. Good night. Take care. Hope you enjoyed the session.